for coming. My name's Courtney. I'm with the trauma program. This is obviously our first trauma grand rounds of the year, so thank you for coming. So the topic today is complications of trauma. So we're going to go through some things that we can prevent and then some things that we might not necessarily be able to prevent. So we're going to talk about some respiratory complications, some complications that it can occur with our kidneys, hypothermia, lots of good stuff. Compartment syndrome, SIADH, so we have one of our neurosurgeons coming, Dr. Piazza, Lexi, who's one of our ortho NPs. So lots of good stuff today. Dr. Laporta is going to kick it off. He's one of our trauma surgeons, for those of you that don't know him. So, Dr. Laporta.
Good morning. Thank you all for being here and for all that you do day in, day out. Today I'm going to talk about thromboembolic disease and trauma. I'm going to cover a few different kind of topic areas. I can be loquacious. I'm going to try not to be, try not to go over. I have nothing to disclose, unfortunately. Today we're going to review the etiology of venous thromboembolism. We'll discuss fat embolism syndrome, including diagnosis and treatment. We'll review the literature on venous thromboembolism, and we'll review the Virginia Hospital Center clinical practice guidelines. Okay, so the problem. VTE is associated with increased morbidity and mortality in trauma patients, period. In trauma patients, especially those admitted to the intensive care unit, they're at increased risk for VTE. Major complications of DVT and PE account for as many as 200,000 deaths annually. That's just a rough estimate based on our best accounting across multiple reporting agencies. When prophylactic strategies are not employed, injured patients may have an incidence of DVT approaching 40% and an incidence of PE of nearly 20%. Equally as important is delays when initiating prophylaxis or missed doses of VTE prophylaxis, and this can increase the incidence of DVT and PE significantly compared to when you're making sure that they're getting their interventions done. I think it's important to clarify the language. So VTE, venous thromboembolism, can refer to a DVT, all right, so deep vein thrombosis, or a pulmonary embolus, or both. So it kind of encompasses all of those things. So it's important that we just, the words matter. So like when we say DVT, it's got to be a deep vein. When we say PE, it's specifically referring to clots that have broken off and traveled to the lungs. For the purposes of this discussion, we're going to kind of just focus to the lower extremity. So the deep veins, so these are not the superficial veins. These are not the veins that you're seeing kind of like dilated in older folks or alcoholics, those superficial veins. We're specifically mostly referring to the external iliac vein, the femoral vein, and the popliteal vein. These are deep veins, so they're not close to the surface. Clots form there, and clots, when they break off, can shoot up and cause problems. When it comes to the pulmonary artery anatomy, and when we talk about PE, we talk about a massive PE, quote unquote, or subsegmental PE. It kind of has to, it depends on, one, how much clot and where it's kind of landed. So envision the lower legs, a clot breaking off and then shooting down. The question is how much clot or how much inflammation, and I'll get into this a little bit, how much inflammation is going on and where are these clots landing? If they're landing in kind of these distal branches, not too big of a deal. Depends on the patient and their underlying risk factor. But if a big clot breaks off and lands in one of these main branches, these patients can get really sick really quick. So again, it's just important that we kind of review kind of the different locations of where these clots are landing. It's the pathophysiology, Virchow's triad. Virchow was a German pathophysiologist who studied autopsies and determined that clotting was due to three main things. So intimal damage, so this is direct tissue destruction or destruction of blood vessel walls. Venous stasis, which in our patient population can occur from paralysis, prolonged immobilization. They either came in and can't walk and are waiting to get going, or they're having too much pain and they're having difficulty mobilizing that immediate post-operative period. Hemorrhagic shock, we can't anticoagulate these patients because they're in a shock state, so we're not able to give them interventions that we would normally give. And then hypercoagulability. Trauma injury is a pro-inflammatory state. And these patients remain inflamed at least first few days, first few weeks, first few months after injury, and I'll discuss that a little bit more in terms of how we try to protect them. Again, these goals of any of these interventions is to try to decrease the likelihood of these kind of bad effects occurring downstream. Long-term complications, chronic venous insufficiency, post-thrombotic syndrome. Think of your chronic medical patients that you see. Think of your chronic surgical patients that you see. Think of those chronic ruddy induration of the lower extremities. That is long-term sequelae of end-stage venous damage, which is kind of the same concept as kind of post-thrombotic syndrome, where when you've had clots in your legs, the veins and the pressure builds up with back pressure, and you develop these collaterals. So blood flow is not returning, and the pressure gradient between the venous side and the arterial side and the skin kind of leads to kind of breakdown. So the concept is still the same. Chronic PEs that remain untreated, these patients can develop pulmonary hypertension long term. So it's important that we try to get them thinned and treated and get these clots broken up, or do everything in our power to try to prevent them from happening in the first place. I'm going to pivot into fat embolism syndrome. Has anyone seen fat embolism syndrome here?
We had a patient who had a hip replacement, who had a fat embolized shower.
Okay.
It was
How long ago was that?
maybe 10 years.
Okay.
Mm-hmm.
And what were the symptoms, if you don't mind?
She started with neurological symptoms. She started with cardiac. We started doing a 12 lead her arm, and then she started with the lip smacking, and then she stopped breathing.
Oh, no kidding.
Yeah, so it was pretty quick progress. She had a shower.
And then
To the ICU and pressers, and she made it about a week.
she made it.
About
Did she
a
die?
week. Oh, yes.
She died. Anyone else? Come to think of it, there was a 15-year-old who had bilateral femurs. Does anyone remember that case? Sorry, I realized that as I was putting the slide together.
Was that last year?
No, it was last year in the sense of, I think it was December,
Oh.
which is like 2 weeks ago. But no, does anyone remember? I thought he went to the ICU. We got ICU people here, right? Does anyone remember that? I thought he had ended up having to get, Courtney, do you remember? Remember the 15-year-old?
Yeah.
He had bilateral femurs.
Mm.
And I think we had to transfer him to the unit. And I apologize for not remembering the specifics between the ACS and the trauma side, but I think he ended up having clinically fat embolism syndrome. He did not die, but I'm pretty sure. And he was kind of a point of setup. We'll kind of talk about that again. So fat embolism syndrome is rare, less than 200,000 cases estimated to occur in the United States every year. It was first described by another German pathologist 150 years ago. It's most often associated with orthopedic trauma, and that's really kind of specifically why I bring it up and put it in this presentation. There are rare cases of fat embolism syndrome that have been reported to occur following bone marrow transplantation, osteomyelitis, pancreatitis, alcoholic fatty liver disease, and even liposuction. That's actually one of those kind of little branch what ifs. When people are doing liposuction, they can kind of break off. And it kind of makes sense if you think about it in the shower. Since most cases of fat embolism syndrome occur following orthopedic trauma, the available research that the little research that does exist on FES is in the orthopedic trauma population. So epidemiology and how does it occur? So fat globules have been detected in the blood in up to 67% of orthopedic trauma patients in one study. That number increased to 95% when blood was sampled in close proximity to the fracture site. So this is really kind of interesting stuff. Hypoxemia may suggest fat embolization, which causing a subclinical fat embolism syndrome. Almost all patients monitored with continuous pulse ox following a long bone fracture will have an episode of hypoxemia. And further embolization can occur during the operative fixation, quote unquote, the intramedullary rodding. So right when they're hammering the rod up the femur for stabilization. If you think about a cylinder being driven into kind of a stake, this is literally showering those bone marrow cells into the bloodstream. Intraoperative TEE have detected fat embolization of 41% of patients during the fixation. Almost all patients will have fat globules, will have the transient hypoxia. So GERD, and I'm going to get to, we actually have some diagnostic criteria if we have a clinical suspicion, reported the incidence of fat embolism syndrome of 19% in a small group of trauma patients. Early operative fixation. Now, everyone's definition of early is a little bit different for the purposes of this institution. 12, 24 hours. These patients don't need to go to the operating room as soon as they hit the door, but we really try to get these patients operated on quickly. This is just one of the many reasons for that. Okay, so again, let's go back to definitions. Fat embolism is the presence of fat particles within the microcirculation. The syndrome is the manifestation of those emboli within the microcirculation. And common systemic manifestations include respiratory distress, altered mental status, and this petechial rash. The mechanisms and the pathophysiology is not fully understood. There's thought to be kind of two main schools of thought, the mechanical obstruction and then the biochemical injury. Fat cells in the bone marrow gain access to the venous sinusoids after trauma. These fat cells have potent pro-inflammatory state and pro-thrombotic potential. Again, this is a common theme. Trauma and these injuries are a pro-inflammatory state, which makes that risk much higher. The fat particles will trigger a rapid aggregation of platelets and accelerated fibrin generation as they travel through the venous system and eventually lodge into the pulmonary microcirculation. Pulmonary capillary obstruction leads to interstitial hemorrhage and edema, alveolar collapse, and a reactive hypoxemic vasoconstriction. This is where these patients are developing this respiratory insufficiency or respiratory distress in that perioperative period. Massive fat emboli can lead to macrovascular obstruction and shock. So just like massive PEs can do it, massive fat emboli can do it. Fat cells can also, so patent foramen ovale. A lot of patients will present typically with stroke or other things, but some of these patients can get these fat emboli from that, and it's undiagnosed and typically diagnosed at the time of the clinical changes. So this is a schematic that just kind of describes, so we've got the long bone fracture, the orthopedic procedure, other insult. You've got the microvascular obstruction and the endothelial-mediated pro-inflammatory cascade. You develop microvascular stasis and microinfarction leading to endothelial damage and rupture of the thin-walled capillaries. This is that classic petechial rash. This is why that's the end organ manifestation. So what's going on in the microvascular and what we're seeing them clinically manifest. So again, essentially kind of 4 different organ system deterioration that can manifest all as a result of these fat emboli. This is just a kind of a little bit of a different schematic, kind of reviewing kind of the injury, where the fat cells land, and then what signs and symptoms these patients are demonstrating. This is Gerd and Wilson's criteria for fat embolism syndrome. So you have major criteria of respiratory distress and cerebral symptoms in non-head injury patients. These are patients that have had a documented head CT that has been normal. Yes, I know a lot of these patients may be concussed, depending on their initial presentation and clinical history. Minor criteria include tachycardia, fever, jaundice, renal changes, retinal changes, anemia, new onset thrombocytopenia, elevated sed rate. We don't really order that on our service, or in general surgically. It's not really kind of a test that we like to use, just because very specifically it can be non-specific. Trauma is a pro-inflammatory state. Right after the operation, it's a pro-inflammatory state. So if we check the ESR on every one of these patients, it's going to be elevated. So this kind of goes back to the classically, if we order a test, so what, is it going to change anything? So if an ESR is elevated, the immediate postoperative period, it's not going to change anything. It's like, so what, is it from this or is it from this? And okay, so diagnosis, so it should be clinically suspected in patients with respiratory distress or petechial rash who are at high risk for developing fat emboli syndrome. Treatment strategies. So they've tried. Steroids have been studied, no benefit. IVC filters and thought, no clear benefit. The hallmark of treatment is just supportive management. It's just literally riding out the storm, for lack of a better word. So we want to support all of the organ systems that may be affected, namely the respiratory system. And we also want to be making sure that if they do have clots, or this has triggered other clots, so that embolus has led to venous embolus, that we make sure that we're anticoagulating or surveilling these patients. Very rare that patients with fat embolism syndrome and cerebral edema can benefit from placement of a bulb. I mean, this is an exceedingly rare incident, but in the event, it's kind of got to sit in the back of your mind. Again, operative fixation, trying to get these patients operated on as quickly as possible. And if you think about it, taking your femur, you've cracked it in half, and you've got the open end and all of kind of the little bone marrow cells kind of flicking out. Getting that space closed down and not having that kind of open surface area and all of the inflammation surrounding it, so that it decreases the likelihood that these cells are going to be taken up and showered around the body. Mortality rates from fat embolism syndrome in modern studies suggest that a mortality rate between 0 and 7%. Again, this is a really rare entity. There's not a lot of known that's about it, but typically if we recognize it and we can support it, and these patients don't have significant other major confounding factors, we can save these patients. Okay, alphabet soup. Has anyone ever heard of these organizations? Okay, so these are 4-letter acronyms, 3-letter acronyms. These are major organizations that we as trauma providers really kind of look towards in terms of best evidence, clinical practice guidelines. These are major organizations. They've got great websites. I'm going to go down a rabbit hole with some of the clinical practice guidelines that our protocols ultimately are derived from. There's a lot of really good stuff out there. If you have any doubts or any questions, most of these are readily accessible. I strongly encourage you to Google these and play around with websites, because there's a lot of really good information. So clinical practice guidelines. So remember, there are kind of 3 levels of classes of evidence, and then there's 3 levels of recommendations. The evidence is class 1, class 2, and class 3. Class 3 is retrospective case series. That is the lowest level of evidence. It's just kind of case series and case studies and retrospective reviews of databases. Class 2 evidence are prospective studies and retrospective studies using controls. And then class 1 evidence, which is kind of like the best, but it's also the most difficult and time-consuming for a variety of different reasons. These are your prospective randomized controlled trials. So These clinical practice guidelines, a bunch of researchers or a bunch of clinicians will look at all of the literature periodically, break down all of the papers, kind of categorize it into the different classes of evidence, and then offer recommendations. Recommendations fall into a similar kind of structure of levels, 1, 2, and 3, with 3 being the lowest recommendation and 1 being really, strongly recommended. Level 1 is convincingly justifiable based on available scientific evidence. This can be based on class 1 or strong class 2 data. Level 2 is reasonably justified based on current evidence and strongly supported by expert opinion. This can be supported by class 2 data or a preponderance of not so good data. But if there's a lot of it, that kind of helps. And then level 3 is just supported by current data. The level of evidence is really severely lacking. And some topics are, in some disease processes, and can be really difficult to really study well scientifically. So this is the Eastern Association for the Surgery of Trauma. Their actually annual meeting is right now, actually in Florida, come to think of it, everyone's been. This is, and I'm going to go through a whole series of slides here. They've got a wonderful, wonderful whole section on kind of best evidence. So it's snippets, so it's easy to digest. And it just kind of talks about literally kind of the history of why do we do what we do. And I really kind of want to go through them briefly, and then we'll kind of segue into kind of what our policies and protocols are. It's kind of scary to think, at least, this based on this kind of sentinel kind of work in VTA, that the oldest studies that they quote is from 1995. So this is a study that looked at the effectiveness of the SCDs for the prevention of venous thromboembolic disease in orthopedic trauma patients. It was a prospective randomized study of compression alone versus no prophylaxis, right? So putting the SCDs on or not. And it showed that SCDs in orthopedic trauma patients showed a reduction in VTE and hip fractures, period. So why do we do what we do? Well, just taking the last 30 years, use this as kind of starting as a base. Prospective study of VTE in major trauma, this is from 94. It's the initial study that showed that VTE is common among trauma patients and occurs in up to 58% of all patients. What agent do we use? Low dose heparin with low molecular weight heparin versus Lovenox in major trauma. This is a study that out of the New England Journal of Medicine that demonstrated that Lovenox was more effective, or the Lovenox and its cousins were more effective than low dose heparin in preventing VTE after major trauma. Both interventions were safe. Routine prophylactic vena cava insertion in the severely injured trauma patients. Okay, if they're at high risk, why aren't we putting clots in them? Let's looked at a subset of patients that were given IVC filters because they were deemed to be so high risk versus historical controls. Patients were given filters if they were high risk with head injury, spinal cord injury, complex pelvic fractures, hip fractures. And those patients had a lower incidence of PE than historical controls. Now, this is going to change a little bit, so this suggests that we should be putting filters. And yes, this was a study that suggested that there was some evidence that they definitely helped, which kind of makes sense, right? If everyone's so at high risk for clots, let's put filters to try to catch them. But there was one major issue with that. Does anyone know what that is? Why don't we put filters in everyone? Can we get them out? So the problem was, sometimes we put them in, or if they get lost to follow-up, one, clot burden can increase and you physically can't get them out. And I think I'll talk about that a little bit more, but yes, great idea, expensive, good money generator and all this other stuff, but in the same regards, if you physically can't get them out, that is a major, major problem. And, anyone who's had any experience with kind of these major vascular stuff, I mean, they erode, right? This is metal. in a vein, and long term, these things can cause problems. So again, use it kind of selectively. This looks at 1,600 episodes from the NTDB, which is a major data bank that we populate patient trauma patient information into. And it just identified risk factors for the development of VTA. Now we're starting to get into some good stuff. This is the early 2000s, a prospective evaluation of the safety of Lovenox in VTE in patients with intracranial injuries, which in this study showed that Lovenox can be safely used for prophylaxis when started 24 hours after hospital admission or after craniotomy, so timing. And again, I'll get into that in terms of our specific policies and procedures. This study here at the top is a randomized, double-blinded, placebo-controlled pilot of anticoagulation in low-risk TBI, delayed versus early Lovenox prophylaxis. And this found that TBI progression rates after starting Lovenox in small, stable injuries after 24 hours are similar to those of placebo and are subclinical. So it's safe, but we have to document the stability. You all will hear that a lot here. Are they stable? Is the head CT stable? The next study just describes kind of these protocols with kind of these triggers. So making sure that we have order sets that kind of help it make it easier for us as clinicians to, one, remind, and two, order the appropriate treatment. So I know it can be difficult and sometimes annoying, kind of the constant alerts, but it definitely has shown, and evidence suggests this, that with these computerized decision tools, our compliance with VTE prophylaxis has resulted in lower rates of events. This is a RCT from the mid-teens in severe brain injured patients. They looked at TQIP patients with severe TBI with a GCS less than 8 compared to initiation before or after 72 hours. And early VTE prophylaxis was associated with decreased PE DVT, but there was no increase in late neurosurgical intervention or death. So again, we were trying to really study to see how safe and how early we can start this VTE prophylaxis on these patients because they are such high risk. This is a systematic review and meta-analysis, just kind of describing the IBC filters. This is another study looking at low molecular weight heparin versus unfractionated heparin, so essentially heparin versus Lovenox in TBI. Patients with severe TBI from the American College of Surgeons Trauma Database were compared to VTE prophylaxis type, and Lovenox was associated with less VTE and better survival. The next study looks at the association between Lovenox dosing and adjusting with anti-factor 10A trough levels. Has anyone ever done this? Does anyone know what that specifically refers to? Anyone? So just because we give a patient a dose of medicine that is supposed to decrease their clot risk, how do we know it's really doing that? So anti-10A levels monitor the essentially kind of the effectiveness of Lovenox to kind of make it simple. So the question is, different sizes, different drug metabolisms, and I trained at Fairfax. We used to do these tests. So we would be checking them like do you remember, Courtney? Like every 36 hours? Does anyone have any experience with this? What, go ahead.
I just remember doing them on my first unit when I started at Georgetown. We were doing heparin drips and Lovenox. We were drawing anti-10XAs like once a day, twice a day. Like it was a lot of troughs. I just remember.
Correct. And do you think it helped?
I think it caused more problems for the nurses because
Uh-huh.
then they're stressing about titrating
Uh-huh.
a drip on a med surge level where they have 5 to 6 patients, and then you're going up and down more. I didn't think it was that helpful.
I completely agree with you.
Yeah.
Sorry. And this to me, there is this, this illustrates one of those large, because depending on what time it was being done, and then, I mean, these aren't like point of care labs, right? So they go down to the lab and it takes hours, and if it's off hours, this is where, for those of you who know me, look, my bachelor's in nursing, I was at the bedside until 3 days before I started residency. This was the large disconnect between the reality of doing things and the theory scientifically. And just because it's a good idea doesn't mean the execution is good. It's a pain in the butt. And were patients actually getting it done? And then how long was it taking? How much lag time? And then again, I'm just not quite sure. There are all of these other factors that I think just make this a way more complicated topic. And I will say, we specifically don't, we do not do that here, but some places do it. I think I'm getting towards the end. Sorry, I apologize. 30 minutes. Sorry, I just want to keep track of time. Spine trauma. So this was this top study was a retrospective review that essentially demonstrated that Lovenox was safe and effective in spine patients. Aspirin, and I'll get to this kind of towards the end. Aspirin versus Lovenox for VTE prophylaxis in orthopedic trauma patients. This is a patient-centered randomized controlled trial. This is literally from 3 years ago. And they randomized aspirin versus Lovenox, and it demonstrated no evidence of superiority. So there was no difference between aspirin and Lovenox. We'll kind of get to that in a skosh. Last study right here is a 2-year review of non-operative spine injury patients, looking at the TQIP database, and this compared patients with VTE prophylaxis after 48 hours. So patient comes in with a spine fracture, maybe mild hematoma, no evidence of, they get an MRI, there's no evidence of epidural hematoma. So again, we fight this battle with when are we going to get bleeding, and when are we going to get clots? And what is this kind of this equipoise, this optimal timing? Because we definitely don't want them to bleed into their spine. That's but we also don't want them getting clots. So again, it's really difficult kind of balancing this. And essentially in non-operative spine patients, so this is a very specific, these are not the patients that have focal motor or sensory deficits that need spine stabilization. These are the T10 fracture that has intractable pain and can't get around. Those patients should get VTE prophylaxis, and they should get it early, period. Okay. If a tree falls in a forest and no one is around to hear it sound, doesn't make a sound. Anyone? Yes? Okay. So if a CPG is created and no one reads it, or they forget where they can access it, does it really, like, what is its utility? And look, I love CPGs. I think that, and the reason why I specifically included ours, and I'm going to go step by step because there is too much information in medicine these days. Our access and our means of acquiring this information and staying up to date on the policies and procedures, it's okay. Just go look it up, is the short of it. So this is literally screenshots. So you go to the homepage, right? This is the intranet homepage. So top right, trauma department, trauma manual, and then these are all of the policies. So this is kept as up to date as humanly possible. I love, again, this is a good resource, and I very much view it kind of as a, I don't want to say like protecting yourself, but just like I look at the East guidelines to, quote unquote, defend your you know what I mean? Well, why did you do this? Because these are the suggestions, these are our guidelines, these are our policies, and these are our procedures. And certainly some things need to change, and we have those mechanisms for doing it. But in terms of why do we do what we do, we try to follow these rules as best as we can, as much as we can.
They're also in policy stats, so all of our policies and clinical practice guidelines are all also in policy stats. So 2 places for you guys.
Yeah, sorry. Again, it's just I think it's really important. I think that they're great, and every place has them located in different spots. So this is literally our policy. It's from it was last year, right? That you two updated it? That's okay.
Yeah.
Yeah, sorry. So it's, again, like anything literature, how old is it? And, these policies and procedures are regularly reviewed and regularly updated. So this is literally our VTE prophylaxis guidelines, describing risk factor categories, moderate, so age greater than 40, blood transfusion, surgical procedure within 72 hours, immobilization, malignancy, extensive soft tissue trauma, hormone therapy. A lot of these, your long-term, like breast cancer survivors. So remember, like the SERMs, those medications can be pro-inflammatory, for lack of a better word. Obesity, high risk factors are age greater than 60, GCS less than 9 for greater than 4 hours, major venous injury or repair, personal history of VTE. We got a really old and really sick population mostly here. A lot of these patients come in and either have a history of, remote history or personal history of DVT. Lower extremity fractures, multiple spine fractures, pregnancy. Remember, pregnancy is a prothrombotic state. And then you have your very high risk factors, spinal cord injury with deficit. So spinal cord injury with deficit. Complex or multiple lower extremity fractures, major pelvic fractures, multiple long bone fractures, and then age over 75 or with any high risk factor. So age plus these. So our patients get 30 Q12 within 24 hours unless otherwise kind of specified. We want to make sure that we monitor the renal, so this is why their labs in the ED are tremendously important that we get, because we want to know what their kidney function is like. Nothing like doing our patients even more damage by giving them a medication that will damage their kidneys. And for patients on the upper end of the BMI scale, BMI greater than 40, we recommend increasing that dosing to 40 Q12. Exceptions, so Lovenox is held morning of surgical procedures unless otherwise specified. VTE prophylaxis will be initiated within 72 hours after injury or procedure for most intracranial hemorrhages and after craniotomy. One of the reasons, there's several of them, why we do these kind of routine imaging, and to be honest with you, I think for all of the routine imaging that we do, it definitely has kind of the most evidence in terms of demonstrating stability, right? We want to prove that that brain injury is stable before we start giving these patients, we start thinning their blood. And like anything, just like any kind of bruise or swelling, you're going to have that blossoming period in that initial post-injury phase. For patients with spinal cord injury, so these are your high-risk spine patients, right? Patients with injury, VTE prophylaxis is held and resumed 24 hours unless otherwise specified by the spine surgery team due to the patient's condition. Again, the operating physician that's involved in those cases knows how bloody these cases were and how their level of concern. So we leave it ultimately up to the spine surgeon's discretion. I think that's a completely reasonable thing. Surveillance. We do not do surveillance. It's ultrasounds are ordered only when clinically indicated, so pain or swelling in these high-risk patients, but there's not really any evidence that routine surveillance. And then IVC filter placement should be considered paraplegia, quadriplegia, vein injury, severe pelvic fracture, or long bone fracture. fracture, complications of contraindications to the AC. And then these patients, we need to make sure that they're getting, so an IR will take care of this, making sure that they're getting retrievable IVC filters and that we're trying to stay on top of them and get them on schedule to get removed as soon as possible once they've kind of gotten out of that phase. So this is the next policy, and then I'm almost done. Is the surgical management of traumatic orthopedic injuries. So this guideline only applies to acute traumatic orthopedic injuries, so within 24 hours of admission. And this describes the surgical intervention in patients. And it was done in combination with ID and trauma services in orthopedic. I edited out, so this is our long bone, our open fracture CPG is kind of this slide before this, but I wanted to specifically use that the end of this policy describes pre and post-operative anticoagulation. Why are we putting these patients on it? And when it comes to what we're doing, so isolated upper extremity injuries, these patients are not going, there is no indication, and we will not routinely put these patients on prophylaxis post-discharge. Pelvic trauma depends on operative versus non-operative. Lower extremity proximal to the knee and then distal to the knee. And again, this is based on kind of the best evidence in trying to decrease the likelihood of these events occurring. Patients can handle complications, in my opinion. They want to know that we tried our best. We know that, and personally, I think we all kind of have this obligation to know that we did everything that happened. If somebody gets a clot, okay, I'm just going to bail themselves out. I want to know that we did everything in our power. And again, I think patients can handle that as well. That's why it's important that we start educating them and their family members early in this period in terms of the role, what we're doing, why we're doing it. So we all play a role. This includes the SCDs and the shots. Oh, I don't want the shots, or yes, they're bothering me and all this. Okay, great. But if you get a blood clot, or you go home and you come back drop dead, so. So to review, VT after trauma is problematic. Fat emboli syndrome is a rare entity, but is typically readily treatable. Research continues on diagnosis and treatment in VTA, and all of our VHC trauma clinical practice guidelines are readily available. Any questions? Yes.
I have a question about VT. For our physical and occupational therapy departments, we have an algorithm of
Okay.
when to mobilize patients with a known DVT.
Okay.
Of course, mobility helps prevent DVT.
Mm-hmm.
When they have a known DVT, we wait for a certain amount of anticoagulation, depending if it's upper and luminal, et cetera, until we mobilize.
Huh.
That's outlined by the APTA,
Okay.
American Physical Therapy Association. I was wondering if you've heard any, and we've had.
I did not know that, so thank you. This is, and can you email me that? Sorry.
Sure.
Like anything, we're all learning here.
Yeah.
So, and certainly we don't do as good of a job as we can crossing disciplines with, and I'll make sure, to be honest, I think about that slide, I'll make sure I throw on STN. I was an STN member way back when and actually went to their meeting when I was a very
Is
young
that something that nursing should be aware of as well?
What? The
Like,
policy?
yeah.
Totally agree. I think that we have generational differences here as well, and people want to know. And I don't think there's anything wrong with that. We need to be able to put that information in places where they can access it, rather than just doing the rumor mongering. Oh, I heard this, or all that stuff.
I'm happy to share that. I was
Yeah.
going to say there are definitely cases where the patient isn't appropriate for anticoagulation, so we always encourage our team to reach out to the surgeon
Mhm.
and talk about when mobility is indicated.
Yeah.
There are definitely situations where it's not so black and white, but I was curious if you had read any research about mobility post-known DVT or
No,
DVT.
I don't. I mean, I am of the mindset that we should mobilize these patients as quickly as possible. I am a big proponent, and I mean, going back to the good old days when I was a resident, we mobilized, we piloted it, we wrote about it. We got colorectal patients up in PACU. I had mapped it out. If anyone was at an over with me back then, I literally counted out the paces because they said, you can't do that, right? Nothing is better than telling somebody you can't do something. And we had those patients after APRs walking in PACU. We had all sorts of criteria that we developed. So mobilization, as far as I'm concerned, and certainly things, I mean, look, we've been talking about this for years. I've got schematics of like stick figures from like the papers from the 1920s talking about like, yes, get the mobilization. It's like, yeah, no duh. This is important, right? So, no, I don't know, but that was awesome. That was amazing. What was that?
That made it.
Is that chapter?
That gravity is still real, is it?
Is it?
It's,
Anyone?
Sorry.
No, it's okay. It was amazing watching
I
it go
couldn't
down.
have done it
It was like
better
Plinko.
if I tried. Oh my gosh.
It was amazing.
No, and yeah. So thank you.
Sorry.
Sorry. Anyone else?
I did not like your answer.
Yeah, no. I appreciate. No, I appreciate your time. I'm still trying to work on. I'm definitely trying to work on ways to kind of make my presentations better in this forum. I think this is a great forum that we have. So, anyone else have any questions? Any thoughts? Anything that we can do differently as attendings? Please. Do we need to do like a suggestion box where, like, yeah, we'll do it like Ted Lasso style. Yeah, we're just gonna throw that one away. Okay.
Justin did find that
What?
15-year-old. You were correct.
Did he?
Yeah, he was admitted to the ICU for respiratory distress and was thought was PET embolism.
Yeah. I
It did
mean, look,
stabilize his situation.
thank you for finding that. I want to make sure the next time that I do this. Sorry, we've had a really busy week, as you all know. And I'm sure everyone's had a busy few weeks with the holidays and some of the stuff that's been going on clinically here. So he did, and I wonder. I guess I wasn't involved. I do cover a lot of nights. So. Okay. Well, thank you seriously, everyone, for all that you do. Please, there are no silly questions. We certainly, want to know if there are things that we can be doing better or different. Okay. Thank you, everyone.
So we submit our data to TQIP, Trauma Quality Improvement Program, and they benchmark us against similar hospitals of level 2 trauma centers that are similar size to us. And we were actually an outlier for DVT prophylaxis. So that's why we've been doing
Good
a
or
lot
bad?
bad.
Okay. Sorry.
Not far. Like we were not like we were not like in the red, but it just we definitely have an opportunity there. So we did a lot of work to find out why we were an outlier and where we can really improve. So that's why we updated our CPG. We worked with orthopedics, we worked with neurosurgery to make sure that we were giving our patients DVT prophylaxis in the appropriate time frame. And we looked at the evidence like from the EAST guidelines and the ACS guidelines. And then we also found too that, so this is where like you guys specifically come in. We found that a lot of times it was documented that the patient refused their DVT prophylaxis. And a lot of times it's because, like Dr. Laporta said, they're like, no, I don't want that shot in my belly. So our ask is that when you have a patient that does refuse it, we're not asking that you guys like argue with them or say like, well, you really need to have this because of X, Y, or Z. The trauma team is willing to go to the bedside and educate the patient as to the importance of them receiving it. And if it truly is that they don't want an injection, there are other means that we have, other medications at our disposal that they can receive instead of a Lovenox injection. So we've actually been working with Epic if you guys, because we completely understand you guys are very busy, you have a lot of patients that you're taking care of. So we were like, how can we take that kind of human factor out of it, of you guys calling us every time somebody refuses. So we went to Epic and we said, hey, is there a way that when you have a refusal documentation of Lovenox or a DVT prophylaxis, can you send an alert somehow to the trauma team to say, hey, such and such patient refused their DVT prophylaxis? So that's something that they're working on their end. We have it worked out, but unfortunately there's a little snafu with it. So every time, we wanted it to trigger every time you guys document refusal. That way, in real time, they can go to the bedside and educate the patient and have that conversation. But unfortunately, right now, it's triggering that alert message to them every single time somebody opens the patient's chart.
Oh.
So they were like, "Do you want us to go ahead and proceed with that?" And I was like, "No, they will kill us." So that will create severe alarm fatigue. So we're just holding on it for right now. So
We all know how bad that can be, right? I mean, we're all, let's clarify.
Yeah.
We all share the same stuff. It may have different kind of specific flavors to it, but we can all empathize with the over-alerting, over-notification, what's important, what's not, pain in the butt patients, right? No, I mean, seriously, right? Sorry, like, we all suffer together, even though, yeah.
oh yeah, plenty of times. that
Yes,
you're
ma'am,
like,
sorry.
Is pharmacy also included in that notification?
That's a good question.
We actually didn't have them included in the notification, but since now there's a delay in pushing that out, we have reached out to, we work specifically with Mona. Mona comes on rounds with the team in the morning. She's fabulous.
Have y'all met Mona? Okay, Mona, I mean, I totally agree, sorry.
Genuinely one of
She
the
is
smartest
awesome.
people I've ever met.
I absolutely think that her presence has
Yeah.
single-handedly, again, it does, you know, she's the expert in that stuff. She'll check the rules, she'll check all of that stuff, so, and I think that's a good thing.
But we asked her, is it possible for the Omnicell when you return DVT prophylaxis to send us an alert? It sounds like that's not possible. So we're working through some kinks to see what we can do. So.
Is the message just for when you chart in the bar, like not given, refused, or is it also for like the flow sheets when you put bilateral, STDs, refused?
So for us specifically regarding our TQIP measures that we benchmark, we can't count SEDs. They're still important. We want you guys to use them, but that's not something that we submit. So we tailored it for the medication specifically. Yeah. All right. Thank you so much.
Thanks, everyone.
She goes in.
Yeah.
Might not have had a chance to meet her yet, but she is newer to us. What, like 3 months? But Allie is, she's a nurse on the trauma team, so she's one of our trauma performance improvement specialists. So she comes to us with lots and lots of trauma experience, and she is going to talk about
So like Whitney said, I am new to the trauma team here, but the last 6, almost 7 years, I've worked ER and level 1 trauma, either in DC or the last 3 years have been at Fairfax. So a lot of crossover in the trauma world in this area. Like he was saying, he trained at Fairfax. I still work at Fairfax in the adult and the pediatric ERs part-time, while I also do trauma performance improvement here. So we are going to talk about rhabdomyolysis, or rhabdo, as we're going to refer to it. As a disclaimer, this presentation is just for informational purposes. I am not a doctor, I am a nurse, so I will not give you medical advice. This is just reflective of the current research. The great thing about medicine is research is always changing. We're always trying to get better, so things may change in the future. This just reflects on most recent research that we've got so far. This section is a little bit interactive, so I will ask questions, and I am prepared to wait an uncomfortable amount of time until someone answers. Okay. I just want to know that you all are awake and not sleeping with your eyes closed or open, either one. It doesn't matter if it's correct. I just want you all to be thinking kind of about this process, the implications for your patients. And again, this is a safe space. Wrong answers are fine as long as you are actually trying. As far as our objectives, I want you to understand just basic pathophysiology. We could get very detailed, but things going on at the molecular level don't necessarily matter as much. It's just overall understanding what's happening and some of the complications that happen because of rhabdo. You should be able to recognize common symptoms, presentations, and kind of the cause, basically. I want you to be able to correctly treat patients with rhabdo and also understand why knowing about rhabdo is important for patient care, especially in the setting of trauma patient care. We'll talk a little bit about non-traumatic rhabdo as well, but mainly trauma patients with rhabdo. So what is it? So Shakespeare said, "What's in a name?" Right? In medicine, kind of looking at the names of things will tell you a lot about what's going on. So rhabdo is just kind of from a Greek term referring to rod-like or striated. If we think about different kinds of muscle, you've got smooth muscle, which is usually your involuntary GI kind of muscles, versus your striated, which is both your skeletal muscle and your cardiac muscle. Both can be affected in rhabdo. Usually it's skeletal muscle, but there are some studies that show cardiac necrosis in very severe forms of rhabdo. So it does affect both, generally the skeletal muscle though. Myo, again, just referring to muscle, and then lysis, referring to breakdown. So rod-like muscle breakdown is basically what rhabdo is and what the name suggests. Lysis, if you think about your hemolyzed lab samples, when lab calls you and says, "Hey, I can't use this metabolic panel because it's hemolyzed," it's because the red blood cells broke down. They released too many things, and now the sample won't run correctly. Or like thrombolytic medications, if anyone who's given TPA, it's kind of how we refer to it. It breaks down the clots. When we've got muscle cell breakdown, just like you have with red blood cells, you have a release of muscle cell components and contents. So the main four that we worry about with rhabdo is going to be myoglobin. You've got your creatine kinase, which will come into play later. You've got potassium, and then your lactate dehydrogenase. We don't use lactate dehydrogenase levels very much. The main thing that's important with this is it's an enzyme that eventually produces lactic acid. Okay. So you've got muscle breakdown. So what happens after the muscle cells have broken down? So you've got myoglobin that's released into your bloodstream that will eventually go to your kidneys and clog the tubules, the filtering part of your kidneys. This picture just kind of shows you've got your muscle, you've got your myoglobin, it's going from the muscle cells into the vasculature. There's a lot of other things going on here that we won't touch on as far as inflammatory markers, different tissue necrosis factors. But mainly it's myoglobin, you can see at the very top, potassium, that's going into your intravascular space. Okay. You've also got some oxidants that cause injury, but again, that's a little bit detailed. Once you've got your myoglobin, your potassium that's in your intravascular space, it goes to your kidneys, going to the tubules, the filtering parts of your kidneys. The main takeaway from that is these myoglobin molecules are actually big molecules, and they're too big for your kidneys to handle all at one time. If you've got a little bit of muscle breakdown, say you took a long run, you did some weightlifting, you're going to have that myoglobin release from the muscles, but it's enough for your kidneys to handle, right? It's a little bit, as long as you're well hydrated, typically you're going to be fine. When you have a large amount of muscle breakdown, you've got too much myoglobin, so it is going to get stuck in your kidneys. It has an oxidative effect. If you think about metal, when it oxidizes, it rusts. Anytime you have oxidation in your body, there's some kind of inflammation and then an injury from that. So that's what starts happening in your kidneys. Not what we want, right? Kidneys are pretty important. They don't regenerate. Once you've lost it pretty much forever. So you've got these large molecules that are now clogging your kidneys, so they can't filter. You've got fluid backup, but you've also got actual kidney tissue damage that's happening as well. Okay, bit of a problem there. Not like what we like to see. 10 to 50% of adult rhabdo patients will get an acute kidney injury. Based on different studies, about 40 to to 50% of pediatric patients with rhabdo will get an AKI. Kids they're very, I like to say rubbery, they're very flexible, they bounce back a lot better than adults do in a lot of ways, but they also have a lot less reserve than we do, so once they start to tank, they have tanked. It's the same thing with their kidney function, right? Once they've got an injury, they've really got an injury. 15% of AKI yearly is due to rhabdo, and about 8 to 15% of yearly admissions every year are due to acute kidney injury. So you can kind of see how this affects our system, our healthcare system, kind of on a larger scale, right? It all adds up. But there's also more, right? Because we just talked about myoglobin, but there's 3 other things that get released. Okay, so we've got potassium release, which causes hyperkalemia. What do we worry about with hyperkalemia? Cardiac issues, right? So increased risk of cardiac dysrhythmias, right? EKG changes. This is just a good look at once you start getting hyperkalemic, some kind of basic EKG changes you tend to see based on your serum potassium level. So as you can see, as it starts getting higher and higher, your QRS starts widening, okay? You start trying to figure out which one is actually QRS and which one is actually the T wave, right? Because that T wave starts getting peaked, it starts getting longer. When you think about a long QRS, what do we worry about with that?
RMT syndrome.
You get an RMT, and then what's another cardiac dysrhythmia that's got a wide QRS complex? VTAC. That's my next little one, right? Can very easily transition over into VTAC, which with pulse we're doing okay, without a pulse, not so okay, and that can very easily convert into VFib. So that's something that we worry about with our rhabdo patients, right? Not just the kidney function, but also the hyperkalemia. Also, your kidney function goes down, you also can't process potassium as well either, right? So it's kind of like a positive feedback. This is just getting worse and worse the longer it's untreated. And then that increased lactate dehydrogenase, that just is increased lactic acid eventually. What do we worry about with that? Once we have more acid in our body, acidosis, right? Acidosis is very kind of a general, lots of different patients have acidosis, but it does kind of lead to other complications. One of them, especially in trauma patients, is DIC. Kind of a complicated pathway, but eventually the acidotic nature, it prevents you from clotting as well, which is also a problem in trauma patients. If we're thinking about patients who have multi-trauma, who have hemorrhagic shock, this is just compiling this whole cascade of reasons that they are so ill, and that can lead you to rhabdo and DIC. So causes of rhabdo. So we've got traumatic and non-traumatic. Traumatic, a big one is polytrauma. This is just multi-trauma. So MVCs, so multi-vehicle accidents, MCCs, motorcycle accidents, or collisions, we say. Earthquakes, explosions, things like crush injuries, so especially people on construction work sites, people who work with heavy equipment, who can have it roll over on top of them, or have heavy machinery crush them or pin them for a long period of time, right? Even if they don't have significant fractures, that soft tissue damage is still occurring, and so you're still having muscle breakdown even if you don't have significant fractures. Things like compartment syndrome, so that's a complication we see in trauma patients sometimes, especially lower extremity trauma. Most commonly in the calves, but it can happen in the thighs and the upper extremities as well, right? You're having muscle breakdown and you get compartment syndrome to the point where it starts causing damage. Prolonged immobilization, so comatose patients, patients who are intoxicated from alcohol or opiate use, surgeries that require specific positions post-surgery, right? People with unstable spinal fractures, patients that don't have very good mobility due to hip pelvic fractures, due to spinal cord injuries, laying in one position, eventually you will get muscle breakdown, right? It's not just the skin breakdown that we worry about a lot of times in hospital patients, it's also the muscle breakdown. If you work in the ER, especially in an area with a large elderly population, it's very common to get calls where we say, hey, no one saw this 80-year-old gentleman for 3 days, we did a wellness check, we found him laying on the ground, right? He couldn't move. He's now laid on his side for 3 days. Eventually, that hip muscle, those leg muscles, they're going to start to break down, and they will eventually get rhabdo. Patients who have suffered abuse or torture, like I said, lower extremity fractures, prolonged tourniquet use. It's one reason that we are very careful when we use tourniquets as far as marking the time, because we want to know how long that tissue's not had blood flow. The longer you don't have blood flow, the more breakdown you're going to have. Patients who have had high voltage electrical shocks, electricians, construction workers, people who've been struck by lightning, obviously not as common, but it does happen. Patients who have had seizures, especially seizures like syndrome, Legionella, and then actually flu is a big one, especially for our pediatric population. They tend to get viral myositis, so viral muscle inflammation a lot more quickly than adults will. And in our pediatric population, flu is a big cause of rhabdo. So what does it look like? So there's 3 classic symptoms. We say classic, I say that in quotations because less than 50% present with all 3. But you may have 1 or 2, if not all 3. So myalgia is muscle pain. Kind of makes sense. Your muscles are breaking down. That's not going to feel good. So about 50% will have myalgias. About 30 to 40% will have myoglobinuria, which is basically myoglobin in the urine. It causes it to look what we say tea color. So glass of tea there for you to remember. But about 30 to 40% will have this, and then you'll have muscle weakness. So not very pronounced, unique symptoms other than the urine color. And if your patient has laid on the ground and now they're dehydrated, is it dehydration and their urine is just concentrated? Is it urine rhabdo and that's why their urine is that color? Other symptoms, so you might have symptoms of dehydration. And EKG changes is a big one, right? So again, as that potassium rises, we might see peaked T waves. We might see a lengthened QRS complex. Has anyone ever treated rhabdo or had a patient with rhabdo? Okay. What is a test that we usually do for rhabdo? What's something that helps us differentiate it? CK. And that's going to be our most sensitive test. We're going to see elevated serum CK levels, right? Because creatine kinase was one of those things that was released from the cell. Normal is about, depending on your lab, is about 20 to 200 international units per liter. The lower level of rhabdo starts at about 1,000. There's really no upper limit. I mean, you can see patients who have hundreds of thousands, like levels in the 700,000, 800,000 levels. It really just depends on the level of muscle breakdown that they're experiencing. Yep.
If someone has less muscle to break down, like they're like frailer, would the number typically be, do you know if the number would typically be lower?
It might be a little bit lower. Again, it's going to depend on the amount, but it's also going to depend on your body mass too. So that will kind of skew it. But anything they usually say over 1,000 is going to be technically rhabdo. As far as treating it, our best thing is aggressive IV fluid hydration. We've got to filter out all that myoglobin. So IV hydration is going to be very important. A lot of these patients are going to have catheters placed for good I and O output marking. Which IV fluid would probably not be a good choice, thinking about what's going on with rhabdo. So normal saline is actually okay.
We use it, though.
Yeah, we use it. It kind of depends, but it's not the worst one by any means. A lot of times we'll start on normal saline and then we might change it a little bit, but that's not a bad one. So LR is a big one. It's already got potassium in it. Anything that contains potassium, we don't want to add to that. That's already our problem. We're just going to make that worse. Depending on your protocols, a lot of times they'll have some kind of, sometimes they'll have like a D5 half normal saline. If you think about your hyperkalemia patients, when we treat them with IV insulin and then dextrose, that does help kind of move it from the bloodstream into the cell. So sometimes D5 will be a good choice. Other times we'll add bicarb because that's going to help correct our acidosis a little bit. But pretty much nothing with potassium in it. Another big thing, so potassium reducing medications, Kayexlate is a big one. Takes a little bit to work, but it is pretty useful in that getting potassium to be reduced. We want to monitor their urine output. Our goal is about 200 to 300 milliliters per hour. So again, always is going to be very important, especially if they're trauma patients. Do they have fractures? Do they have mobility issues? If you're wanting 200 to 300 milliliters per hour, that patient cannot be getting up to the bathroom every hour up and down. Okay. We want to monitor for DIC, right? Already a big problem in trauma patients. They're already kind of predisposed to it. Oxygen supplementation, right? If we're getting fluid backup from kidneys that are shutting down, we're going to have respiratory problems. So, respiratory support. We want to trend our serum CK levels. We want to make sure what we're doing is actually helping. Do we need to be more aggressive with our fluids? Are we getting better? Kind of where are we in our treatment? And then correcting the cause, right? Especially with fractures, if you think about them, when they're unreduced, they're out of place and they're pressing on muscle. So especially for like femurs that are out of place, open fractures, getting them reduced and back in place as soon as possible is going to correct that cause. Electrical shocks, I can't really do anything to correct that. It just kind of is what it is. But some of these other things we can kind of prevent. If it's a medication issue, we can stop those medications. We can treat snake bites. There's lots of things that we can do to try and correct the cause or at least mitigate the effects of it. And then in severe cases, our patients might be started on hemodialysis, whether it's CRRT or just a more kind of periodic dialysis, at least until their kidney function hopefully returns. We can get some of that myoglobin out, get that kidney function back. But if it's too severe, they might have to be on dialysis until they can get transplanted. And then intubation and mechanical ventilation if we are in such an advanced state that we have respiratory failure as well. So why is it important? Overall, it's got a 14% mortality rate. If acute kidney injury has occurred, it's now a 42% mortality rate. Okay? The leading cause is trauma that we see in the United States. BHC obviously is a level 2 trauma center. We're going to continue to have more trauma patients coming in. Sometimes we get them as trauma activations, but there's also a significant amount of patients that we get from other hospitals that are trauma patients that have transferred in. And especially these patients who have had trauma 12, 24 hours prior, they could already be in rhabdo and not be very well treated, or start having complications from it. So we still kind of have to watch these patients. We think, okay, like they're stable, they've been transferred, but we still have to watch for complications like rhabdo. We also have an increasingly aging population, right? People are living longer. As our population ages, we have people living on their own who are prone to falls, that might not have people checking on them. You've got increasing statin use. Statins and hypercholesterol are just so common in our culture, and especially in our aging populations. We don't really think about it. We think, okay, I've got high cholesterol, but I take a statin, it's fine. We don't really think about how that kind of predisposes us to rhabdo in general, and then also with other medication interactions.
If someone's already got rhabdo, should we expect their statin to be held during their hospital stay?
They may or may not. It's going to depend on the cause. So a lot of times statins will interact with a lot of antibiotics. So you can have that kind of complication. In that case, they'll probably change the antibiotic more than they'll hold the statin. But
But it
that's
won't like further.
not necessarily. It's usually more with another medication that it'll interact with. Any questions? Yeah.
Aside, you're talking about monitoring DIC. Why would DIC occur?
So with DIC, when you start having acidosis, it starts affecting your clotting factors. So it affects both your platelet activation, but it also affects the effectiveness of clotting factor 7. So you've got your clotting cascade, you've got your platelet side of it, you've got your clotting factors. When you take out one of the clotting factors, you've kind of just taken it out of the knees. It's kind of like a domino effect, and you've just taken out a chunk of the dominoes. So some of the cascade happened, and then the rest of it can't continue. So So when you start getting extremely acidotic, you start having your clotting factors won't work as well. You just cut out about the middle of the clotting cascade. It's why if you've taken like TNCC or ATCN, they have the trauma triad of death, and acidosis is one of them. That's part of it. Any other questions? These are my references, and that's it.
If you guys want to take a quick 10-minute break.
Matt Piazza, I'm a neurosurgeon here at Virginia Hospital Center. I've been here for about a year and a half now, because I haven't met yet. And so I was asked today to talk about sodium abnormalities, particularly a neurosurgeon's perspective. So I'm not a critical care expert. I don't actively manage a lot of these sodium problems, but we see a lot of these patients, as neurosurgeons because, neurosurgical pathology, neurosurgery itself is associated with sodium problems. So, I'll try to sort of give my insight into these problems and how we think about them as neurosurgeons. So no disclosures, background. So just a general outline for today. Why is sodium important? What do neurosurgeons care? And then to talk about sort of neurosurgical specific types of hyponatremia and hypernatremia. So why is sodium important? Why do we care about it so much? So it is the major soluble osmotically active agent in the serum and extracellular space. And osmotically active substances are those that sort of interact with water, resulting in the flow of water in and out of spaces. So osmotic agents dictate where water goes. So because sodium is the major osmotically active agent, it is what determines volume status in our patients. Those are some important terms here. So what is osmolality? Well, that's the concentration of a dissolved substance that is osmotically active, a kilogram of water. So, and again, osmotically active agents are those that determine osmotic pressure. And what is that? Osmotic pressure is the hydrostatic pressure needed to resist the movement of water in and out of a space. So, for example, if you have sort of envision two compartments with separated by a semi-permeable membrane that only water can flow across and dissolve a substance in one compartment, and that substance is osmotically active, it's going to draw water into that compartment. And that pressure, so the osmotic pressure is how much force you have to apply to that water to resist the flux of the water across that membrane into the area where the solute is dissolved. And so why is osmolality important? Why is volume status important? Well, if the serum osmolality changes in the extracellular space, that's going to change the cell volume as water leaves the cell or enters the cell. And why is that important? It can lead to abnormal cellular function if there are too drastic changes in terms of the cell volume. This is particularly important in the neurons, which the concentrations in and outside the cell can determine sort of the depolarization of neuron and hence neuronal function. And so, how is sodium regulated? Well, by how much fluid we take in and how much we put out, intakes and outputs. There's a complicated hormonal control pathway, the hypothalamic pituitary axis, as well as the renin-angiotensin aldosterone system, are all very important for sodium regulation, as we'll hear about in a second. And then plasma osmolality, so how much that solute with volume solid. And so, again, the hormonal regulation of serum osmolality is particularly important for neurosurgical patients, as we'll see. And so basically how this works is there are receptors within the hypothalamus that detect the serum osmolality. And so, for example, if the osmolality is too high, the hypothalamus signals to the pituitary gland to release ADH, or antidiuretic hormone. Also goes by visibleness. ADH acts on the distal convoluted tubules in the kidney to absorb free water. And that's going to decrease sodium and decrease osmolality. And so then there's that feedback loop where the hypothalamus detects that decrease in osmolality and then it sort of tapers off its stimulation of secretion of ADH. And again, this figure here on the left just shows in more detail what's happening in these osmolar receptors in the hypothalamus, the influx and efflux of water from these receptors signals that sort of change in osmolality. That's what triggers the hypothalamus to stimulate or decrease the amount of ADH production. That's very pituitary. Like I said before, the renin-angiotensin-aldosterone system plays a significant role in homeostasis of sodium osmolality. Specifically, the adrenal gland releases mineralocorticoids, aldosterone. And this alters, it regulates the sodium water absorption in the kidneys and potassium excretion. You can see how that's going to change osmolality. We won't talk about that too much. So, why is sodium homeostasis important for neurosurgeons? Like I said, a lot of the pathology that we see can cause sodium abnormalities. Some of the most common instances where we see it are in subarachnoid hemorrhage, aneurysmal rupture, and that can be associated with usually it's cerebral salt wasting, usually bowel or SIDH. Pituitary or cellular type lesions pathology can cause dysfunction of the hypothalamic pituitary axis, and that can result in sodium problems. And we just talked about the importance of the hypothalamus and pituitary for regulation of osmolality and sodium. And then in severe TBI, traumatic brain injury, you can see either hyponatremia or hypernatremia. We do procedures that can lead to problems in sodium balance. For example, after pituitary surgery, manipulation of the pituitary stalk, that can result in loss of that regulation of sodium. Hyponatremia can be a marker of neurologic events. For example, in the subarachnoid hemorrhage population, if there is a sudden drop in the sodium, that can be a precursor or associated with delayed cerebral ischemia or vasospasm. And clearly in our patient population that's neurologically frail to begin with, any major aberrations in sodium can lead to neurological dysfunction. So how do we classify hypernatremia versus hyponatremia? So normal serum sodium is defined between 135 and 145 milligrams per liter. So we define hyponatremia as less than 135 milligrams. Hypernatremia is greater than 145 milligrams. So with hyponatremia, milder symptoms include nausea, mild headache, confusion. In more severe cases, you can get cardiopulmonary distress, seizures, lethargy, and coma. In hypernatremic patients, it's typically complain of lethargy and muscle weakness, but again, in more severe cases, seizures or neurologic deficits, and rarely intracranial hemorrhage. And both of these are associated with mortality in critical care patients. Now, the way we think about the management of sodium problems, there are four major important components. The severity of the abnormalities, of how hyper or hyponatremic the patients are. This influences sort of the goals of correction and how we approach correction. The duration of abnormality, so if it's acute or subacute versus chronic. Patients who have chronic hyponatremia, even if it's severe, may have little to no symptoms versus those who have an acute, relatively mild hyponatremia, may have more significantly affected. The plasma osmolality itself helps understand why patients may have hyper or hyponatremia, and then same thing is said of volume status as well. So hyponatremia, we classify this as mild, moderate, or severe based on the concentration of sodium in the serum. Again, mild between 130 and 135, moderate 125 to 130, and severe less than 125. Again, when we think about the time scale of things, we sort of classify an acute hyponatremia as less than, it's sort of occurring less than 48 hours. And subacute or chronic greater than 48 hours duration. Now, patients who have an unknown duration of hyponatremia, so those patients who show up in the ER with little history, we assume those to be chronic cases. That's because there are dangers to too rapid correction of chronic hyponatremia, which we'll talk about. And then tonicity again, so the plasma osmolality will dictate how we work this up. So we classify. So this is hypertonicity is greater than 295 milliosmoles, and hypotonicity is less than 275 milliosmoles. So what are the causes of hyponatremia? How do we work it up? So in a patient who has hyponatremia, the first thing to determine is the osmolality. And that'll dictate whether or not this is a hypertonic or hypotonic state, or isotonic. Now, isotonic hyponatremia is pretty unusual. We call it pseudohyponatremia, and that can be caused by, in cases of patients who have very high elevations of triglycerides, which interferes with the laboratory testing for serum sodium. And so these cases are not really true hyponatremia, but so then patients with hypertonic hyponatremia oftentimes can be seen in patients who are hyperglycemic or after mannitol therapy or they have relatively high level of osms from the mannitol administration and so on. And then hypotonic hyponatremia, we then look at the urine osmolality, and if it's low, then that is suggestive of low sodium intake. So we see this sometimes in patients who have what's called psychogenic polydipsia, where they have excessive intake of free water, and some patients who have chronic ecstasy use or who drink large volumes of beer. And in patients who have high urine osmolality, this is when the urine is inappropriately concentrated. There's too many osms in the urine. So then we can break this down further into volume status. So in patients who have a normal volume status versus those who have decreased, so in terms of neurosurgical patients, the most important diagnosis here is patients who have SIADH, or syndrome of inappropriate ADH secretion. Their volume status is usually normal to somewhat increased sometimes. And in patients who have decreased volume status, we further look at urine sodium. If it's elevated, then these patients, it can be caused by what's called cerebral salt wasting, which is diuretic use, and then in those with low urine sodium due to extrarenal loss of salt, the GI tract and the spleen. Patients who have increased volume status, those are patients who have things like heart failure or renal failure. But sort of this very complicated diagram to take home is that we look at the serum osms, the urine osms, the volume status, the urine sodium to really sort of get a better sense of what's causing what. And again, from the neurosurgical side of things, the most important diagnosis here is SIADH and cerebral salt wasting. So syndrome of inappropriate diuretic hormone, antidiuretic hormone. So as we know, that ADH is very important in terms of the regulation of serum sodium, serum osmolality. What we get here is that there is a release of antidiuretic hormone without an osmotic stimulus, and the result is a dilution of hyponatremia. So the general diagnostic criteria here are low serum sodium, low serum osmolality, a high urinary sodium, and normal renal and adrenal function without signs of hypovolemia or dehydration. there are a number of causes of SIDH in the central nervous system. Basically, most intracranial pathologies can lead to SIDH. So infections, head injuries, bleeds, subarachnoid hemorrhage in particular, brain tumors, inflammatory conditions of the brain, so anything neurologic can result in SIDH. We see it post-surgically, which we'll talk about some more, in particularly in cases where there's manipulation of the hypothalamus and pituitary. Non-neurologic causes that can be seen in malignancies, particularly small cell lung cancer, and there are certain medications that can cause SIDH, endocrine problems, pulmonary issues. But again, from my perspective as a neurosurgeon, we deal with this mostly in the context of central nervous system problems. And so how do we manage SIDH? Again, it depends on how severe the hyponatremia is and the duration and how symptomatic the patients are. And so in patients who are asymptomatic with mild to moderate hyponatremia, or in patients who have severe hyponatremia but are asymptomatic and it's considered to be chronic, sort of the initial management is fluid restriction with dietary supplementation of salt. The idea here is by limiting the fluid intake, it decreases the amount of fluid restriction. It decreases the amount of volume available for reabsorption in the kidney. If those methods fail, then conivaptan, which is an antagonist of the ADH receptor, can be utilized. In cases of symptomatic but mild to moderate hyponatremia, or chronic hyponatremia that is mildly symptomatic and severe, this is sort of the next escalation of therapy, typically by administering normal saline with Lasix to help diurese, and carefully monitoring the sodium to serial sodium checks. And again, if these measures fail, then conivaptan can be administered as well. In severe cases of hyponatremia that are severely symptomatic with duration less than 48 hours, typically we would move these patients to the ICU, administer hypertonic saline, administer Lasix to the volume of the room with careful monitoring of serum sodium and monitoring and replacing electrolytes as needed. Now, the other major neurosurgical condition that we see hyponatremia in is cerebral salt wasting. And this is a hypovolemic hyponatremia, the setting of future criminal disease specifically. And it's most commonly seen in the setting of aneurysmal subarachnoid hemorrhage. But it's seen in a variety of neurosurgical pathologies. And this results from a renal loss of sodium and as a result of extracellular fluid. There's really an unknown mechanism. We don't really understand why in this specific diagnosis this happens. And it can mimic, the challenge is it can mimic SIDH, but the main distinguishing factor is hypovolemia as opposed to euvolemia or hypervolemia in SIDH. So, and this is just to illustrate, that SIDH and cerebral salt wasting can be very similar. So they low serum sodium. There can be low serum osmolality in both SIDH and cerebral salt wasting. Urinary sodium can be elevated in both conditions. The main distinguishing factor here is dehydration or volume loss, so hypovolemia. So probably the most sensitive ways to assess this are looking at venous pressure and looking for clinical signs of dehydration. Dry mucous membranes, tachycardia, loss of skin turgor. The reason why it's so important to distinguish between these two is fluid restriction in the setting of cerebral salt wasting can be catastrophic. So the way to treat cerebral salt wasting is typically with normal saline infusion or with hypertonic saline in severe cases. And this will correct both sodium and volume. If aggressive line resuscitation is needed, use of isotonic fluids is preferable and much more about that in a second. Dietary supplementation of salt. Fludrocortisone can be administered just directly, increases sodium absorption from the kidneys. We generally don't want to use Lasix in these cases of furosemide because that can lead to further solute loss and exacerbate the salt wasting. And again, we want to avoid the use of fluid restrictions which increase blood viscosity and may precipitate ischemia in the setting of ambulatory hemorrhage patients. Again, major take-home point here is SIADH versus salt wasting is difficult to differentiate. And again, looking for clinical signs of hypovolemia is probably the most important way to distinguish these two. If there is any sort of question, you want to challenge the normal sodium bolus with this perfection of sodium is left through the salt wasting. And again, not food restrict the diagnosis is clear. This can precipitate or exacerbate vasospasm and ischemia in patients with subacute hemorrhage. Like I said before, salt wasting can be a precursor to some of these ischemic events. Where drops in sodium secondary to salt wasting can be a precursor to vasospasm and DCI. So you definitely don't want to further restrict these patients. Now, one of the major complications of correction of hyponatremia is central pontine myelinolysis. And this occurs from rapid normalization of sodium, particularly in patients who are chronically hyponatremic over the course of a short period of time, 24 to 48 hours. And this can result in mental status changes, cranial palsies, and eventually quadriplegia. And so, in patients who have severe hyponatremia or suspected chronic hyponatremia, we want to limit the normalization of sodium by 8 to 10 milliequivalents over 24 hours or 25 milliequivalents over the course of 48 hours. If you suspect CPM, or central pontine myelinolysis, you should stop treatment of the hyponatremia and administer the DHP. So one of the issues with correcting hyponatremia, particularly in those cases where cerebral salt wasting we want to replace volume, is something called hyperchloremic acidosis, metabolic acidosis that can lead to an inflammatory response and ultimately a decreased perfusion secondary to cerebral vasoconstriction, hypocapnia, and so we see this most often in patients with cerebral salt wasting. We're pumping them with fluids that are hypertonic. So in normal saline or hypertonic saline, where the amount of chloride in solution is significantly greater than what's seen in plasma. So for example, normal saline has a 154 milligrams per liter of chloride, which is significantly greater than what we see in normal plasma, which is about 100 milligrams per liter. And so, particularly in patients with salt wasting who have sort of already are at high risk for cerebral ischemia, you want to avoid this particular complication because it can lead to further cerebral ischemia. And so the best way to address this is by avoidance rather than correction. So if you anticipate that this patient will require large volumes of fluid for volume resuscitation, and you want to switch these patients to isotonic fluid, then it's relatively well balanced composition of electrolytes for aggressive augmentation. When it's suspected, though, when the patient has hyperchloremic acidosis, you want to administer sodium bicarbonate or sodium acetate. Now, switching gears a bit to hypernatremia, we can categorize this based on tonicity. So either it's isotonic, hypotonic, or hypertonic. And again, as you can see, there are a variety of different etiologies of hypernatremia, but what we see most often in neurosurgical patients is diabetes insipidus, which results from pure water loss. So diabetes insipidus is an abnormality in the HPA axis where not enough antidiuretic hormone is produced. So it's the exact opposite of SIADH. And there are neurogenic causes and nephrogenic causes. And we're going to focus on the neurogenic causes here. And a along with hypernatremia, these patients have high urine output, and in conscious patients, they experience increased thirst. And so, the diagnostic criteria here, as we look for dilute urine, so looking at specific gravity, typically less than 1.03, high urine output, so 250 cc's per hour over 2 to 3 hours consecutively. So 250 cc's per hour over several consecutive hours. Normal to elevated sodium. The sodium may lag the urine output in some cases, so it may not be hypernatremic right off the bat with normal adrenal function. So if the adrenal function is impaired and the kidney can't make free water, they can't move the body. So similar to hyponatremia, there are a number of neurostructural causes. You can see traumatic brain injury, herniation syndromes, tumors that either cause mass effect or direct involvement of pituitary stump, hypothalamus, so craniopharyngiomas, metastatic tumors, lymphomas, pituitary apoplexy, where there is sudden loss of perfusion of a massive and necrosis of a massive pituitary tumor, giant aneurysms that can compress the pituitary stalk or hypothalamus, central nervous system infections, inflammatory conditions, also can be seen in idiopathic subtypes. So interestingly, in pituitary tumors, pituitary adenomas, we don't really see it so much in the setting of very large adenomas, even though there can be compression of pituitary stalk, hypothalamus. So these rarely cause DI, but it can be seen, like I said, in apoplexy, where there's a sudden loss of perfusion and necrosis of the pituitary tumor. We do see it very commonly, though, after resection of pituitary tumors, particularly in the transfemoidal group, so going through the nose. And it's usually transient, but it's commonly seen. So there are three potential presentations we see with diabetes insipidus in the setting of transfemoidal surgery. So there's a transient DI that resolves typically 1 to 2 days after surgery. A more prolonged DI, which can occur for months, and in about a third of cases is permanent. And then in some rare situations, we see what's called a triphasic response, where there's some direct injury to the pituitary stalk that leads to low secretion of ADH. And then when the pituitary cells die from that injury, they release large amounts of ADH into the bloodstream. So they have a sort of a rebound effect where they became hyponatremic. And then after that, that sort of release of ADH resolves, they become hyponatremic again from DI, and usually in that sort of prolonged phase. And so we oftentimes will actually every single patient who gets transfemoidal surgery, they should have a serum sodium check about a week after surgery to confirm they don't have that triphasic response. Because obviously that can be catastrophic, sort of hyponatremia in the outpatient setting. So in all transfemoidal patients, and in particular patients who undergo craniopharyngiomas that don't have transfemoidal surgery but sort of craniotomies, there should be serial sodiums, strict INO measurements, urine specific gravities, and like I said, on post-operative 7, serum sodium to make sure they have that triphasic response. The other time we see this pretty commonly is in severe traumatic brain injury. There's herniation. And this either can result from shearing the pituitary stalk directly or brain death, in which case there's no viable hypothalamic function. And even in these cases of brain death, it's very important that DI is appropriately managed, especially if organization is to be considered. So how do we manage DI? So in conscious patients with a preserved thirst mechanism, you can get up and go to the bathroom. In mild cases, we typically advocate to drink the thirst, at least for the first couple of days, to replace the free water deficit. Because like I said, in many cases, if patients get DI after pituitary surgery, transfemoidal surgery, this resolves after a day or two. In patients with severe DI, can't keep up, meaning they can't take in adequate free water, or their urination is so high volume and frequent that they can't get to the bathroom every hour and it's interrupting their sleep and quality of life. In those cases, we'll administer DDAVP use desmopressin, either PO or nasally. In patients who have an impaired thirst mechanism, are neurologically not able to sort of get up and out of bed or comatose, these patients you want to replace their free water deficit in a cc per cc fashion. So it requires strict I&O measurements, careful monitoring of serum sodiums and osms, and using D5 on abnormal saline for replacement of the urine output. And if fluid replacement is ineffective, then they can get either vasopressin or desmopressin. So, in conclusion, the major takeaway points of this talk, is that sodium homeostasis is very important for volume status and cellular function, neuronal functioning. And sodium abnormalities are commonly seen in neurosurgical patients. Important considerations when doing the work and management of hypo or hypernatremia is the duration of the symptoms, the severity of the sodium abnormality, the tonicity of the osmolality of the serum, and the volume status of the patient. It's important not to correct hyponatremia too quickly, especially in patients with chronic hyponatremia, as this can lead to catastrophic complications of central punctate myelinolysis. And then hyponatremia caused by SIDH or salt wasting can be difficult to distinguish, particularly in neurosurgical patients, because these conditions can occur in both. These conditions can occur with similar pathologies, so hemorrhages, pedigree. So if there's any uncertainty, never fluid restrict, and usually the normal sodium level is a safe test. In the hypernatremic patients with DI, the most important factor to determine how to manage these patients is their ability to independently satisfy the thirst requirement. And those who can't keep up with their I's and O's, should continue to do. So that's all I have for today, and thank you for your time. Questions? Thank you.
Okay, hypothermia in trauma patients specifically. Is hypothermia something that we can prevent in our patients? Preventable or unpreventable? Yeah, definitely. Unless they already come to us cold, which is why we try to engage our EMS providers as well, because oftentimes they're picking up the patients, off the side of the road or wherever they might be picking them up. And because of the weather outside, especially now, maybe not today. Today it's just raining, but like 60 degrees. But in the wintertime, it's cold outside, right? So the ambulances need to be warm inside. And Justin can speak more to that, but I know oftentimes when they bring trauma patients to us, they're cranking that thermostat up inside. So not only when they arrive to us, they themselves are sweating, but the patients should ideally be as warm as possible as well.
EMS is terrible at it. Seriously. Most of the time when patients arrive, they're cold. Because it's very difficult to do your assessment, keep them covered up, you're trying to reassess, trying to keep it out of the patient. It's difficult to do with patients, bubbled up and cocooned in a way. So, expecting to be cold. And they don't regularly monitor temperature, right, of the patient. So our average transports in this area for this hospital is like between 4 and 7 minutes. So in that short little period of time, if you're not Johnny on the spot telling your supervisor, whoever it is, turn the temperature up in the back of the unit, because when we get in the back, we want it to be 85 degrees, whatever it needs to be. Sometimes that doesn't happen. So anyway, expecting to be cold. Sorry.
So I lied. I was trying to be positive.
I know you were. I appreciate it.
So what is hypothermia? So obviously it's a potentially dangerous drop in temperature. Normal temperature or euthermic is 98.6 degrees, like we know. or somewhere around there. I know tons of times patients will be like, well, my normal is 97. The book says 98.6 is our average. So, when should we be concerned? So, mild, moderate, and severe hypothermia. So mild is 96.8 to 93.2 degrees Fahrenheit, and then you guys can see moderate and severe there. The majority of our patients come to us around 96.8 degrees. There was a study, and we'll get more into it, but that looked at trauma patients globally, and the majority of them, 50 to 60%, come in with temperatures around 96.8 degrees. So we're already kind of behind the eight ball there, like Justin alluded to. So prevention is key, and that's where we come into play as best we can. So let's get into it. So what happens when you go to the gym and you exercise? What do you usually do? What happens when you sweat? You sweat. And then you get in your car, you might turn the air conditioning on, right? Then what happens? Yeah. You get cold. You start shivering. Yes. So same kind of concept with our trauma patients. So what do we do? What does EMS do before they bring them to us? And then what do we do to them in the trauma bay when they initially come in? Yeah, we don't get them warm first. We're terrible at that. We take all their clothes off. We take all their clothes off because what is our primary goal? What are we looking for? Life-threatening injuries. So we do our initial assessment where we're looking at our ABCs, and then we move on to our secondary assessment. And the majority of the time, because I don't want to say that we have like tunnel vision, but for the lack of finding my words, we have sort of tunnel vision in that we're looking for those immediate life-threatening injuries. So we're not necessarily thinking about the aftermath of what can happen when we make them code. So, but we should be covering them back up as we're exposing them and making sure that there are no threats to immediate life, right? But like I said, so we sweat and it evaporates off of our skin, and then we get cold. So same thing with our trauma patients. Initially, whenever the trauma occurs, their adrenaline starts pumping, right? So potentially they're sweating, or maybe they're bleeding, and they have fluid all over their skin, all over their clothes. So we really need to remove those clothes so that we can get the wet clothes off of them. And the one thing that we don't tend to think about is that the sheets that are underneath of them a lot of times are wet and cold as well. So we really need to get a dry sheet underneath of them once we do our initial assessment, and then cover them back up with warm blankets. And then we'll get into this a little bit too, but this is not just for EMS providers and the ED staff. This is for OR staff as well, because obviously what happens in the OR? You don't have anything. So anybody in the OR or near the OR? I'm just curious what we typically keep our OR temperatures at. I would assume around 80 degrees. That's the goal for our trauma bays. It used to be 85 degrees, now it's 80 degrees. I can promise you that our trauma bays are probably not 80 degrees. I see somebody shaking their head no. And part of that is because, and this was always my pet peeve at my old facility, in order to keep the trauma bays at 80 degrees, the thermostat is set that way, but the door's always left open. It's propped open. And that heat just goes out. So they're never at 80 degrees. But what are some ways that we can increase the temperature for our patients? Not only in the room with the thermostat, but what are some other ways that we can add heat to them? And what's another product that potentially trauma patients are receiving? Blood. Yeah. For those of you that work on the floor, do you guys have warming methods for blood products? So something to think about, not even just for our trauma patients, but your little old ladies who have like no body fat on them. It's good to give those fluids warm because otherwise we're making them cold too. So like the ED has several pieces of equipment that they can use to warm blood. So you could always call the ED to see if you can borrow something. Don't tell them I said maybe borrow that.
Courtney, the average OR is between 68 and 74 degrees, so that's pretty. I knew it was chilly.
I think the surgeons like it cold.
Yeah, it's like bacteria and all that, but you've got a trauma patient, and yeah, you've got to really think about if the room has to be bad.
Yeah.
What have you got to do for the patient?
And then you have to think about the storage of your sterile supplies as well. So they want those kept at a certain temperature, and it oftentimes doesn't equate to what you want it for the patients.
Even on the floor, when we're giving blood, blood bank doesn't want us to hold it against our bodies. They want that back cold when we give it to them. I don't know if there's a difference in the time he's on the floor and the time they get in the ED. If it's more of a emergency situation, we're giving it a couple hours. They're giving it
Yeah,
as fast as possible.
that's definitely a fair point because I know that it has to be a certain temperature if you need to return it. So and especially since you guys are typically giving it over like 3 to 4 hours, right? Yeah. Versus like in the ED or specifically for our trauma patients who are requiring blood products, if we're not massively transfusing them, we still likely want it to be in them quickly. So like in the ED, they'll use the Ranger device, which you can put on a pressure bag and still give it fast without putting it on. But yeah, that might be why. So like I said, controlling the thermostat in the room, 80 degrees in the trauma bay ideally. You can also use the overhead lights as a mechanism of warming as well. Like in the OR, those lights are warm, or in the trauma bays, those lights are warm. For those of you that work on the floors, you don't have that light that you can bring down and shine on people. But you do have bear hugger there too, as well as warm lights as well. So, Oh, you don't have a bear hugger?
We have bear hugger.
Okay. Oh, you don't have a
Regular
bucket
blankets,
warmer.
not warm ones.
I know, because you come to the hospital and you're like, oh, nice warm blanket. Give your turkey sandwich.
That's what it is.
And then for that third bullet point there, we're working on this. There are some places that want a temperature for trauma patients with every set of vital signs, like every 3 to 5 minutes. I don't know that that's necessarily ideal or necessary. So us on our end, we're doing a little bit of research to figure out what really is the right answer for us. But ideally, specifically to the ED, we want a temperature when they arrive, and then we want another temperature likely after CT scan to see where we are. If we're trending downward, then we need to implement some other measures, some other prevention measures. So, I see if I missed anything. Alright. So here's just a chart that shows some of the signs and symptoms that your patients might have depending upon where their temperature is, if they're mild, moderate, or severe. And then as well as the recommendations on how to implement rewarming measures. And we're going to get more into that. But on the right-hand side are some rewarming measures. So you have your passive, which obviously removing clothes, adding blankets, increasing the temperature in the room. And then active internal, so that's more once we get towards moderate to severe hypothermia. So endovascular rewarming, peritoneal or pleural lavage, where we'll actually instill warm fluids into the bladder or into the pleural space. And then we get more into needing ECMO or cardiopulmonary bypass for very, very severe cases. I think it was Allie that alluded to the trauma triad of death. And if you guys have been to a Grand Rounds before, then we have likely talked about it at some point or another. But there's an added, they're saying that potentially it's the lethal diamond of death now, because they've added calcium to it, specifically for patients that are receiving mass transfusion. The studies are showing that they're becoming hypocalcemic, so they're recommending that we're giving calcium with anybody that we're massively transfusing. But really, the biggest component to the trauma triad of death that I feel that we can play a part in is hypothermia. It's kind of the easiest one that we can affect by all of the things that we've already talked about. But they all just play on each other. So there was a study done by the military that showed that 60% of patients in the field already had coagulopathies when they arrived to the hospital. So that's not necessarily something that we can prevent because the trauma has already occurred. But potentially we can affect hypothermia that prevents the coagulopathies from getting worse and the acidosis from getting worse and so on and so forth. Allie said it's like a merry-go-round. Those were her words. Merry-go-round that just goes around and around and around, and each affecting the other and worsening. So how do we want to rewarm our patients? Fast or slow? Slow. Yeah, why don't we want to rewarm patients too quickly? So, close, very, very close. So, and we'll get into it a little bit more, but it's called the after drop effect. So they say that if you warm patients, and it's not super closely studied, and it doesn't happen all the time. But if you're rewarming somebody too quickly, then you are shunting cold blood that's making them worse. Let me bring up my slide here. I think I have a slide. But basically, you're taking cold blood from the periphery and shunting it to the core. And that's why you see patients, if you rewarm them too quickly, sorry, I thought I had a slide on it, that they'll have dysrhythmias and things like that, and they can potentially get worse. So that's why they want us to rewarm patients slower. So they recommend 0.5 degrees Fahrenheit per hour. Oh, it's right there. That's what I get for not looking at this one. Rapid rewarming can cause after-drop phenomenon, which is when warm blood shunts to the periphery and cold blood shunts to the core. So we have a 22-year-old male who presented as a full trauma activation, completely unresponsive. He was found down by bystanders outside. He has significant facial trauma from what we think is an assault. Upon arrival to the ED, the patient had apneic respirations that were being assisted by EMS. He had bilateral breath sounds, a weak bradycardic pulse, and was unresponsive with a GCS of 3. So, not good. I'm not super happy about this patient. So he was subsequently intubated upon arrival. Vital signs are blood pressure of 90 over PALP, heart rate of 43, SpO2 of 99 via the vent, and temperature is 80.6 degrees. So to put that temperature into perspective, when they say that patients need to be warm and dead, they need to be 89.6 degrees in order to call somebody dead. So he's very cold. Surprised that he's alive at this point. The secondary assessment revealed multiple facial contusions and a large laceration to the chin. And there's his EKG. What do you guys see on his EKG? This is not a 12-lead class, so don't get scared. I'm not the person to teach that class for sure. But what do you guys see? This is a junctional rhythm. So he's in a junctional rhythm because of the decreased oxygen demands from the hypothermia. Now, what if he were to need to be paced? What if we need to electronically pace this guy? If he becomes even more unstable, if he drops his blood pressure more. Effective or ineffective? We typically, if somebody's cold and they were to need to be shocked, like if they were in VFib or VTAC and we needed to shock them, it's typically not as effective when they're cold. So they usually only recommend that you're going to defibrillate somebody 3 times. And then you really shouldn't defibrillate them again until you've reached 30 degrees Celsius, if it's ineffective. So pacing, if you have to transcutaneously pace them, then you have to do what you have to do. Ideally, transcutaneous is the better method, because if you attempt to transvenously pace them, if you have a myocardium that's already irritated because of the hypothermia and you're introducing something into that space, then you're likely just going to make it worse. So transcutaneous pacing is ideal versus transvenous pacing. That being said, too, just an added tidbit, if we're putting a central line into somebody, which most of the time trauma surgeons would prefer a femoral anyways, but you really wouldn't want to go through the neck because, again, you could potentially tickle the heart, which, again, if it's already irritated, you could potentially throw them into a lethal rhythm. Okay. So, CT scans revealed a small traumatic subarachnoid hemorrhage and multiple facial fractures, including an open fracture to the left mandible. Lab studies revealed lactic acid of 6.3 and a potassium of 2.9. So what do we think of those labs? Agreed. We got some work to do, right? So he needs some warm fluids to start with, for sure. Among other things, many other things. So long story short, his hypothermia resolved within about 3 hours. What do we think of that time frame? That was pretty quick. Yeah, pretty quick. And they used a combination of warm saline, forced air, so like a bear hugger, and warm saline lavages to the bladder as well. The following day, the patient went to the OR for debridement and open reduction of his mandible fracture. And then 2 days after that, he was extubated with no neurological deficits. Good thing he was 22, exactly. And the majority of our patients are not 22, so the majority of our patients would have not likely survived that event because they're elderly and immune compromised for one reason or the other. There is certainly a place for hypothermia in patients. When do we typically use intentional hypothermia? Yeah, post-cardiac arrest, because we're trying to increase blood perfusion to the brain, so we kind of slow it to other places. But typically not in our trauma patients. Typically we like to keep them nice and toasty.
When the patient's down like that outside, how long does it take them to become hypothermic?
It really depends on them and their body habitus, what they're wearing, and if they're cool, if they're in dampness versus dryness. But it's really not very long. I mean, I can speak to. I mean, I'm kind of a baby when it comes to cold, but I have horses, so I'm outside a fair bit of time. In the wintertime, I really don't enjoy it, and I'm all huddled up. But it really doesn't take long to be outside if I'm not appropriately dressed and start shivering and start down that process of.
So certainly less than an hour for someone who's in a situation.
In a situation like this, like, did they intentionally warm the patient that fast, or was it because he was already hurt? Was already so cold that they just had to do something?
Yeah, he was already so cold that I think that they warmed him a little bit too quickly, but he was definitely in a severe state, so they implemented a little faster warming methods. So, and it might also be because he responded quicker too, because he is younger.
Do you have that time whenever the patient's 80 degrees, like to do the half a degree per hour?
Yeah, typically they'll want to warm them a little bit quicker because otherwise half a degree per hour is like, I mean, I need to like pull out a pen and paper, but that's gonna be, I mean, a lot of times you see them warm them over like 10 hours, but I mean, his time frame, he would have been far extended from that. What was that?
I just said like that still would have been.
No, he would have been probably more like 20 hours. So
maybe a non-trauma patient you can rewarm more slowly.
yeah, if they're not as cold as he was too. So, but like I said, ideally prevention is the key. So that's why we do engage with our EMS providers as well. But just know that the majority of our trauma patients that come in, they're around 96.8 degrees, so they're already a little bit cold. So just remembering to cover them as we're exposing them, and it's okay if you see somebody not doing that to say, or just like nicely go up with a warm blanket and be like, I'm just gonna cover them up as you're exposing them so we can keep them warm. So, any other questions? Which one of you would like to go?
Alright, so my name's Lexi Binger. I'm a nurse practitioner with orthopedic surgery for Ortho Virginia, and I work primarily with our trauma service, so Dr. Fleckler, and then also all the other orthopedic surgeons who take trauma call here at BUC. So I'm going to go through some stuff about compartment syndrome. Feel free to stop me as we go if you have any questions, and then we'll go from there, okay? So we're just going to go over what is compartment syndrome, some risk factors for compartment syndrome, how do we figure out if somebody has it, and then what do we do about it? So the definition of compartment syndrome, compartment syndrome occurs when the pressure rises within a confined space, and this causes critical reduction of blood flow to the tissues. So if you think about your arms and your legs, our muscles inside our arms and our legs, they have a thick tissue called fascia surrounding them that kind of holds them in these separate contained areas. That fascia is inflexible, meaning at a certain point, the pressure, it's not going to burst open like a can of biscuits, right? The pressure goes back in to the tissues and the vessels. And so essentially what happens is, I'll tell you in a second. So it's a surgical emergency. A compartment syndrome is a surgical emergency. And we care about it because a lot of really bad things happen if we don't catch it, including myonecrosis, rhabdo, contractures because you have muscle damage, sensory loss. These are highly correlated with high risks of infection, non-union if there's a fracture associated, and then also amputation. We also care about this because compartment syndrome, specifically for orthopedic surgery, although I think it's across the medical specialties, is the most litigious diagnosis that we have. So a miscompartment syndrome is fairly certain you're going to be writing a check to a lawyer. So that's also a reason why it's on high alert. But obviously we care more because of the really bad outcomes, but just in the back of your mind. So when you have that increased pressure, so you have damaged tissue, that causes swelling and increased pressure within the compartment. That leads to reduction of blood flow to the muscles. When there's reduction of blood flow to the muscles, the tissue starts to die, it gets ischemic. And that tissue ischemia leads to the release of more substances into the compartment that then are changing the osmotic gradient, which then further increases the pressure in the compartment. And then we have this vicious cycle that keeps going. So now you have more pressure, you're getting less blood flow, and it just keeps going, repeating itself. So I just wanted to show you, these are kind of, when we talk about the different compartments that we're testing and stuff, you have the lower extremity, like your tibia on the right, and then this is the upper extremity, this is the hand compartments, which there's a lot of them. So who is at risk for compartment syndrome? Well, there was a study, it's kind of the most quoted study that we kind of look at, and it's McQueen. And in that study, there was 164 patients over an 8-year period at a pretty large trauma center. So if you think about that, over 8 years in a large trauma center, 164 cases. Compartment syndrome is not the most common thing that we see, right? So keep that in your mind. It's a scary thing, but it's not like every day we're seeing a ton of compartment syndrome, hopefully. Praise God. Okay. And so what that looked at is of those 164 patients, 69% of them had a fracture associated with the compartment syndrome. The most common is the tibial fracture. 36% of those patients had tibial fractures. They also had about 10% of distal radius fractures that were positive. Now, I want to go over this because I know there's some ER and ICU people here and everything who see a lot of distal radius fractures in the ER, right? So in this study, there was 10% of distal radiuses there was 10% that had distal radius fractures that had compartment syndrome. But if you looked at all of the distal radius fractures that came in that 8-year period, the incidence was 0.3%. So again, it's not something that we see often, but it can lead to compartment syndrome. So I just want to make that little caveat there. And then both bone forearm fractures, right, we're damaging both. They're usually higher energy. That was about 8%. Soft tissue injury without fracture, 23%. So this is typically a crush injury. Something falls on you, you don't break something. Also, people who are like found down. So a lot of IV drug users can have this, especially in hand, but then also if you're found down on your leg, you can have gluteal or thigh compartment syndrome. Something to be on the lookout for. Circumferential burns, because if you have a burn, right, that burn is now rigid, there's no space for the body to expand, and then that can lead to the compartment syndrome. One thing that we do see here, because we are a large cardiac center, is reperfusion injuries. So, if somebody hasn't really had good blood flow to their arm, let's say, for many, many years, and then Dr. Bach goes and opens it up for them, which is great. Well, over that 10 years, a lot of times the veins that take the blood out of your arm, they have kind of shriveled up, as well as the artery, right? If you don't use it, we lose it. That's what I tell my patients all the time. So when they go and open up the arterial flow, if you don't have the venous outflow, you can also get these reperfusion injuries. And then tight dressings and casts, which we all have learned about in school. Typically, compartment syndrome is associated with a high energy injury, like tibial fractures. So if you look at this one, I mean, this takes a lot of energy to have a comminuted fracture like that in the tibia. Other injury or other risk factors include coagulopathies or being on anticoagulation. So this patient who's on Eliquis, we should have kind of a high alert for that patient. And then polytrauma with transfusions. Remember, people might be hypotensive when they come in. We're kind of bulking them up. We're giving them a lot of volume. If you start noticing weird things swelling, keep an eye out for that and be on the lookout. These are two very specific orthopedic injuries. If you see this on an X-ray, you want to be careful. You want to be mindful of that. A medial knee dislocation, and then also a Schatzker 6, which is just the way that we describe tibial plateau fractures. But you can see that this is like a crazy tibial plateau fracture, right? So this would be very high energy injury. So like I said, most cases of compartment syndrome are high energy injuries, but it can occur in relatively low energy or like atraumatic injuries. So you want to be on the lookout. And on the right-hand side are just some of those things where we're putting extra volume into compartments. Compartments really don't like a lot of stretch to them. They don't have a lot of stretch, so anything, an IV infiltration, that could cause it. Let's see, fracture. There is exertional compartment syndrome, which is with exercise. That's usually someone who's not coming into the ER. We see that in the office a lot, where when I run, my legs are so sore. I put my legs up against the wall, it gets better. And so some of the tests that I'll show you in a minute, we do in the office, and they kind of have like outpatient procedures done to try to relieve that. Snake bites, that's a big one. Okay, so recognizing compartment syndrome. We all know this. We all heard this in school. This was on our boards, right? This is common stuff. But pain out of proportion to the injury, pain that's not relieved with proper pain medication, and then pain with passive stretch. So what that means is, with your foot, if I take and I pull back your toe, your big toe, I pull it back, and I start screaming. Now, if I have a broken ankle and I just got it set and I'm screaming, okay, but if you let me rest for a little bit and you pull it back and I'm just going crazy, that would be someone you want to alert the primary team, hey, same thing with the forearm. So if you stretch back their fingers like this, or even like this sometimes, and they start screaming about something hurting, that would be that pain with the passive stretch. So you're just passively doing it. And a lot of times I actually will do it when I'm talking to a patient, so they don't actually know that I'm trying to get a reaction from them, and I'll just go and pull back. And if they don't respond, then that's good sign. Pressure is not one of the typical 6 Ps that we learn, or there's actually in school you learn 5 Ps, but we're going to do 6. But pressure is one of them, and pressure in the sense of swelling. Okay, so I'm going to show you a picture on the next slide. These people, they are swollen tight like a drum. Okay. So it's not swelling like my arm is swollen, but when I touch it, it gives, right? So if you look at my arm right now, when I touch my arm, it moves, right? And even if it's swollen, if you touch an arm and it gives, then that's not really swollen, like we think of with compartment syndrome. Compartment syndrome is typically, it's big, it's swollen, it's shiny, it's tight. When you push on it, it doesn't give, and that's when you should be thinking, oh, this is, I need to be on high alert here. Pallor, so it starts to get pale because you're not getting as good of blood flow. Now, late signs of compartment syndrome would be paresthesias. Nerves are actually more sensitive to ischemia than muscles, so people will start getting paresthesias. Paresthesias alone are not a sensitive indicator for compartment syndrome, right? Because there's a lot of things that can cause paresthesias, but paresthesias with a really big swelling and all these other factors, that would be concerning. If the limb is cold, that's not good, right? Because now we know that we're having a vascular insufficiency from all that pressure. Again, not good. And then pulselessness. Hopefully you never have a pulseless extremity, but if you do, we need to act on it very, very quickly. Just remember that on intubated or sedated patients, you need to have a very low threshold to call somebody with a concern for compartment syndrome because they can't tell you if they're having pain out of proportion. They can't tell you those things. So just be mindful of that. So hopefully you can see with these pictures. So the limb on the right, you can tell it's much more swollen than on the left side. You can see it's sort of shiny, and there's just a lot of swelling. But if you look down here and see the skin on this leg, that is kind of, in my mind, what I think of as a very swollen, tight compartment swelling. Okay, so if you ever read orthopedic notes, a lot of times we'll say compartments soft or compartments tight, and that's what we're thinking of, like that. Hand compartment syndrome is a little bit, it's the same, but a little bit different. So the hand will have tense, swollen compartments, and then they put themselves into something called intrinsic minus position, which essentially is where their fingers kind of curl. So if you ever splint a hand, right, we know that we like to keep the MTPs flexed and then these out straight because that puts tension on things so that they don't get contractures in their splint. If this is causing tension, then when you have too much pressure, you don't like it. And so your hand naturally will kind of curl to relax the compartments. And so if you tried to straighten their hands out, they would freak out. Okay. Now, the other thing with these patients, okay, I always say you can do the eye test. And that's actually at the OTA, somebody talked about that. So, somebody who's sitting on their phone texting, they don't have compartment syndrome. I mean, I guess they could, but very low, right? Someone who's texting. Someone who's saying, you know, I'd like a sandwich. That's not. These are people who, you know, they are, I can't get comfortable. Can you please give me more pain medicine, please? I just can't get comfortable, please. I'm sorry. You know, it really hurts. That is what we're looking for. Someone who's saying, oh, my leg's a little sore. Okay, it's swollen, but do you see the difference? These are very uncomfortable. They can't, their leg is essentially starting to die. They're not comfortable people, okay? So just keep that in mind. If they're texting and eating and doing all that, then we have a little bit of time to evaluate. So the timing, okay? So that same study found that the majority of patients, it was within 7 hours of either their fracture being manipulated or surgery that the compartment syndrome kind of presented itself and was identified. There are delays. 4 out of the 164 people had, over 14 to 24 hours. But typically, like if someone comes in and they say, I fell 3 days ago and my arm is really swollen, if they have a compartment syndrome, that's like a case reportable thing. So this is typically within a short period of time frame from their injury. It's not days and days out there. The other thing with sorry, my papers got all switched up. One other thing I just want to let you know is that in that McQueen study, a big risk factor is being a young, and by young, we mean 12 to 29-year-old male, right? High energy, young male. If you think about it, the compartments in younger kind of muscular guys, they're already full of muscle, and so there's just not a lot of extra room to stretch. So people who don't typically get compartment syndromes, again, there's exceptions to every rule, would be like an older lady who has no muscle. The chance of them getting compartment syndrome is very low because there's a lot of room in those compartments for things to stretch. But somebody who already is full of muscles and is bulky, they don't have a lot of room to stretch. So just think about that. Like younger men, that's who's really at high risk for compartment syndrome. Okay, so what do we do? Well, the initial thing we would do is if they've been splinted, we want to, loosen the splint, but possibly even split it. And that includes splitting the web roll. So we always think web roll is really soft, but if you have enough layers of it, that can be kind of a constricting it. And so if you have like a lower extremity splint on, you almost are never wrong to cut down the front of it. That doesn't mean take the whole splint off. Obviously, you're gonna call and let people know, but you can cut down the front of it. Same thing with a forearm splint. You can always, there's usually a spot that you can cut and loosen it up. Obviously, if you are documenting that you're worried about somebody's swelling or you're worried about someone's exam, this isn't the patient that you document that you're worried about and then you never check on again. So if you're documenting that in your notes, then you need to be following up just like the primary team is following up. You need to follow up and say, hey, I reassessed it and this is what's going on. You want to keep the limb elevated at the level of the heart. So we actually, a lot of times we say really elevate it super high. But remember, this is all about perfusion. And so sometimes if we really elevate something, we decrease the perfusion even more. And so we don't want to like hyper elevate these extremities. But certainly, we don't want it lower than their heart level. Sometimes you'll see patients in traction, and you can release some of the weight of the traction. So there's about 5% increase in the compartment pressure for each kilogram of traction that's on. So sometimes just releasing some of the weight can help with that. Sometimes we tell people to increase the oxygen saturation, so put supplemental oxygen on just to try to really force oxygen into those muscles and the vasculature. And then if they're hypotensive, then we need to be working on correcting the hypotension again because we're trying to get as much oxygen, as much blood flow to the tissue as possible. So you've looked, okay, trauma came down, orthopedics came down, we don't really know what we're going to do. Then we start thinking about, well, should we measure compartment pressures? And I'm sure you've heard of Stryker needles or measuring the compartment pressures. And so some of the reasons why we would think about doing that is if it's kind of like a borderline picture, it hurts, but they don't have all the symptoms. An unreliable exam. So again, they were blocked after surgery, but they have this huge swelling, then we want to look at that. Prolonged hypotension with the swollen extremity and the swelling, that would be a reason to do it. And then you've had a lot of the pain medicine, they were doing okay, and now they're just screaming. Sometimes then we say, okay, well, we'll Stryker it. I will tell you, the majority of, at least for orthopedic surgeons, compartment syndrome is a clinical diagnosis. So we do this test, but if they kind of teach in orthopedics, if an orthopedic surgeon thinks that someone may have a compartment syndrome, they're going to the operating room because you don't want to miss this. But we do use these exams, and I know I've been part of Strykering a couple people in the vascular lab at different places to see what's going on. And on this picture, you can see that how there's that beefy red muscle kind of at the bottom right side of the incision. If you look to the left, you see that kind of like brown, gray, black tissue. That's what we're trying to avoid because that's what happens in a compartment syndrome. The muscle starts to die. Yeah, dead muscle. So when we do the compartment pressures, what we're looking for is two numbers. One is the pressure of the actual compartment itself, and less than 10 can cause muscle damage. Greater than 20, but what we're looking for is the pressure within the muscle itself, and then the pressure within the compartment, and then the pressure of the compartment as it relates to the diastolic blood pressure. Okay, so if the pressure within the compartment is greater than 30, or if the pressure within the compartment is within 30 of the diastolic blood pressure, then that constitutes a compartment syndrome and would be an immediate indication for fasciotomy. So there was one case down in the CB recovery area from a reperfusion case where the difference between her diastolic blood pressure and her pressure was 14. So that just tells you that it's too much. And then if you're in the operating room, we use your preoperative blood pressure. We will take your diastolic blood pressure, we'll document that, and that's what we'll go against because anesthesia, their blood pressure can be wonky and it's not a true blood pressure. When you take a compartment measurement, you always want to take it close to the fracture site. This just shows that the further away from the fracture you are, the less the pressure is, and so to get an accurate reading, you want to take it near the fracture site. And then if you are doing the test, which I don't think most people in this room would be doing it, but these are just kind of where you go to do the striker needle test if you ever had to. So these are the indications for a fasciotomy. Okay, so fasciotomy is the surgical intervention where we go and we open up those tight bands of fascia that are surrounding the compartments to let the pressure out. And I will tell you, when you do a fasciotomy, it's actually super kind of satisfying in a sick way because literally it explodes like a biscuit can. I mean, it is crazy. And the muscle will be kind of gray and look really bad. And as soon as you make that cut and it comes out, it pinks right up, hopefully, if you did it in time. And it really is pretty satisfying. So, one, the clinical findings, that can be a reason. Pressure within 30 of the diastolic blood pressure. Pressure within the compartment greater than 30. Sometimes we do this in patients who have really significant injuries, so we'll prophylactically do a fasciotomy if we're concerned about it. Greater than 6 hours of total limb ischemia time. So if you have a patient who has to have a vascular repair, their limb has been ischemic for greater than 6 hours, we prophylactically do this because we know that once you hook the pipes back up, things are going to, get crazy. And then certain injuries that are at high risk from compartment syndrome, we, again, prophylactically do that. And then the contraindication would be a missed compartment syndrome, which is, again, somebody who was found down, they've been laying on their side for, a few days. When I was working at GW, we had several patients who came in who nobody knew their last normal, but they were found down and we could tell that they had a compartment syndrome in their arm and we would leave it alone. We'll talk about that in a second. So when these patients come upstairs, typically there's different ways of having there's different techniques for fasciotomies. The most common on the leg is 2 incisions, and these are big incisions, okay? Same thing with the arm. That person that I saw in the CD recovery area, her fasciotomy was all the way up to her shoulder, down to her hand. So that's a big incision that we don't close. We don't want to close it. We don't want to tighten it, right? We want to let pressure out. So sometimes we'll put a wound vac on them, and these have been shown to have higher rates for closure down the road. But some surgeons still do, it's called like a Roman sandal technique, where they kind of use these vessel loops to pull the skin together. If they have something like this on, or they can do other suture techniques, but if they have something like this on, they're going to have a dressing, it's going to bleed, it's going to ooze. You're going to call orthopedics and we're going to say, reinforce it. We're not worried. Put a chuck pad under them, reinforce it. We want it to ooze, we want it to bleed, we want the pressure to come out. So I always just say that because everyone always calls me. I say, I know it's bleeding, it's okay. Those patients, typically we go back for at least one additional look at the skin and at the muscle to see, because sometimes muscle can look okay when we first get in there, and then we kind of have to go back and make sure that nothing needs more debridement and stuff like that. Acute complications from a fasciotomy would be one, an infection, right? You have these huge open incisions. And then a lot of times the swelling is so big that these patients need skin grafting to cover the incisions. And so then we get plastics and other teams involved. Chronic complications from a fasciotomy would be, people don't have as good of sensation. They can have altered sensation in that limb. Their scars can get kind of funny. A lot of lymphedema and like postoperative swelling. Muscle herniations, because the fascia is partially what keeps our muscle in place. So if we have holes in it, the muscle can kind of pouch out. Pain, and then sometimes like tendinous injuries. Big complications, this is kind of like the classic one for a missed upper extremity one is a Volkmann's contracture, which is their wrist kind of gets this like flex, and then their hand. You don't want to see it. Infection, neurologic injury, chronic pain, non-union of associated fractures, high risk of amputation with compartment syndromes, and then obviously they're in hospital, increased stay. We know that when people stay in the hospital a long time, something's going to happen. We just know this. So, the complications go up. We will find things wrong with you, and so that that all goes up. And then the last thing is just the missed compartment syndrome that I mentioned. there really isn't good literature to tell you what to do in those situations, but they can have upwards of 46% of infection and 21% of amputation rates. So if you think about a miscompartment syndrome, everything is dead inside in your arm, your leg, wherever. And you can have compartment syndrome in the abdomen, in the eye. You can have it anywhere where there's a contained space. But I'm orthopedic, so we're just going to talk about limbs. But and then a very high amputation rate for those patients because essentially you now have an unusable extremity. So, but those patients, you really want to monitor their kidneys and their metabolic function because, right, their muscles are going to start releasing their potassium. They're going to start going into rhabdo. They're going to have all these issues. And even though we're not treating it surgically, we still need to treat the medical management of it. And for those people, you really don't want to open it up because it's really associated with a high amputation rate. All right, so what questions do you guys have for me? Anything? I went through it kind of fast, but. Hi.
You said that it happens usually very quickly. So if someone's here, they've gotten surgery, and it's a couple days out, you're less concerned that it's compartment syndrome, is that right?
Yeah, I mean, at that point you would be worried, like, is there something going on, like, is there a vascular injury or something? But a lot of times it's just swelling. And swelling is normal. It's just when it gets out of control that you'll be worried. But if they've been here for 3 or 4 days, I would be worried that their splint or their cast was too tight or something like that. But I wouldn't be worried about that acute compartment syndrome from the fracture manipulation.
We're talking about the lady that had incision from her shoulder down to her hand. For compartment syndrome, the fascia covers each muscle.
Groups.
Okay.
So she had actually her upper arm and her lower arm compartments were both the reperfusion because it was a revascularization procedure.
And then I get that you said that opening up a wound or a compartmentalized tissue, whatever, 24, 48 hours afterwards, increased risk of amputation. Does it just evolve on its own if you don't, or what happens?
So that's a good question. So it increases the risk of amputation because it increases the risk of infection. Because now we have all this dead muscle that we're exposing to kind of like the environment. So sometimes if you just let it sit, it will eventually all scar in, but they will have like muscle contractures and stuff. So a lot of times, like with your hand, the hand surgeons will go and do tendon transfers to see if they can try to get you more motion. Foot compartment syndrome, which is one we really don't operate on all that often. You'll get contractures of your toes, and then the foot surgeons will go and do tendon transfers. So there are things that we can do, but the muscle won't heal on its own. It's dead. So then we just kind of deal with, okay, well, what do we do to treat the problem that occurred from missing it?
Is there any restriction, or like what are the restrictions on like mobility for like post fasciotomy patients?
I would say
usually weight bearing restrictions, or
well, a lot of it will depend, right? If they have an underlying fracture, so depending on what that fracture is, usually the first day or so after fasciotomy, right, we'd say we really don't want them to get out of bed. We just want them to keep their leg elevated, kind of hang out. And then as the swelling improves and we get it closed, then we can advance their weight bearing. But a lot of it depends on what was the reason for the compartment syndrome. So that all depends. And some of these patients, right, they'll come in and then they'll have an X-fix on, and then they have fasciotomies, and then they're not going to put weight on it. But you know what I mean? So a lot of times it's a very staged kind of procedure of dealing with the injury and then this, and then going back and dealing with the initial injury and kind of figuring out the timeline.
how long is the typical timeline if they do get the fasciotomy and need like a skin graft? Like what is the, if any, like typical timeline for?
I mean, usually like so.
surgeries?
Let's say they came in on Monday. A lot of times we would take them back to the OR Wednesday or Thursday to look at the skin again. And then sometimes depending on the swelling, we would start trying to close things. And then we might take some pictures and send it to plastics, and then they go back a couple days later. So it depends how quickly we can get it to close and then if they need plastics or whatever. If we have a wound vac on, usually the wound vacs typically stay on, 2 days in between. And also just to give them a break from the anesthesia and everything, so usually like 2 days and then we keep going back and doing the debridements and stuff. But a lot of it also depends if they're doing well versus they're spiking fevers, they're not looking good, then we might have to go back more frequently to kind of clean out dead tissue and kind of see. But we have had a patient with a compartment syndrome, a young guy, he was here for 5 days. We also have had people who have been in the hospital for several months because of sequelae. So it just really kind of depends on the patient. Any other questions? Okay, cool. Have a good day.
They can create a lot of morbidity, but also markedly increase mortality associated with the injuries. And I feel like there's a lot that we can do to prevent them. Once a patient starts to go down the road, we have to play catch up really quickly. But I think, like I said, there's a lot that we can do to prevent these complications. So we're going to talk about a variety of the most common complications. Same thing on my screen. Okay. So, why do people get respiratory complications after traumatic injuries? Well, there are a couple of reasons. The injuries themselves can cause difficulty breathing, right? So if you have a pulmonary contusion, you can have difficulty breathing just on the basis of the injury itself. Pain and anxiety is a huge, huge part of it. And then the hypoxia associated with the injuries and associated, trauma patients don't come in typically, especially our patients have a long medical history and they've got a lot of lung problems associated with it. So hypoxemia on top of whatever lung problems they already had can be problematic. So these are the 4 respiratory complications that we're going to talk about. They're arguably the most common, and again, they kind of go in order of worsedness. That's a word, which it probably isn't. So atelectasis, we throw that word word around a lot, and that's because it happens extremely frequently. So the lung is I don't know if any of you have seen a lung, but it's kind of like a sponge. It's kind of like a sponge. So if you think about, washing your dishes and you take the sponge and you smush it, that's what a lung is like. So atelectasis is just if the lung is smushed. And there's a lot of reasons why that can happen. We'll talk about in a second. Basically, it's either stuff is obstructing it from the inside or pushing on it from the outside. But basically, those alveoli, which are like little air sacs, are smushed down, and they don't have air inside of them, so you can't have the gas exchange. Major risk factors. Anesthesia. General anesthesia in and of itself can cause problems. Prolonged bed rest. We don't see that at all in this hospital, right? Because we get our patients up and moving, right? Shake your head. Shallow breathing. Why do people have shallow breathing? Pain. Pain is a huge one. Huge, huge, huge. But also, what happens when you lie in the same position forever? You're laying on your lungs, and all of the bottom part has all the weight, and particularly if patients are a little bit overweight, you can have significant weight pushing on the lungs. Underlying lung disease, as I already mentioned. Tumors in foreign bodies can also cause this because they're obstructing the airflow from the inside, but it's not something that we deal with a lot on the trauma service. But the other stuff is all stuff that we deal with. regularly. So here are the basic types. Compressive atelectasis is when something is pushing against it, pushing against the lung, causing it to collapse. So if you have a hemothorax with a big blood clot in there, or if you have a pneumothorax pushing against the lung, that's compressive atelectasis. Reabsorptive or obstructive atelectasis is basically when you don't get any more air going in because it's obstructed, and all of the gas that was in the alveolus gets sucked out into the bloodstream, and so there's nothing left in the alveolus, and it just collapses. And then contraction, that's mostly from lung scarring. We see that in patients with retained hemothorax. So if you have a hemothorax, initially what you see is, initially the hemothorax is fluid, it's blood. And then it clots, and it gets to be like a clot. And then it becomes like sticky jello, and it sticks to everything, and the lung can't expand. It kind of forms like this fibrous coat around the edge of the lung. And so that's why we need to get fluid out, especially blood out, as quickly as possible. So those are the basic types. The bottom line is it's all the same pretty much clinically, and we have to get the lung open. We have to work really hard to get the lung open. So some imaging. I think in a former life I was a radiologist because I love looking at x-rays. But this is a picture of a chest x-ray rather, with, you can see the white part up in the right upper lobe. That's atelectatic lung. So that lung is smushed, and there's some fluid, potentially some fluid inside the lung. That's why it looks white against the black aerated lung next to it. Okay. And then on CAT scans, this is an example of a patient who went to the operating room. So before anesthesia on the left, excuse me, on the right, and after anesthesia on the left, you see the dependent portions. Again, those are the areas that get least aerated and kind of most pushed on. Those are the ones that are atelectatic. This, you can see where the arrows are. I'm short, so I won't be able to. Okay, so what can we do for this? As much as we can, avoid anesthesia. Early mobilization. I see our unsung heroes of trauma care in here. I'm very happy to have you here. But physical therapy, getting everybody up. This is why I am such a big proponent of getting people up and moving. Even if they're not going to walk, run down the hallway, even changing their position to sitting up, getting out of bed is critically important. PEEP is positive end expiratory pressure. So anything that we can, any pressure we can put inside the lungs is helpful in keeping the alveoli open. So that's where we get into, like if they're ventilated, then they're on PEEP from the ventilator. But the PEEP can also come from all of the respiratory tools, the Medenebs, the EasyPap, all of those tools, even in centospirometry, will increase the pressure inside the lung because you're taking a really big deep breath. And then in the operating room and in the ICU with the ventilator, we can do things called recruitment maneuvers where we just it's like pushing air into a balloon and leaving it there for a few minutes before we allow the patient to exhale. And that helps kind of pop open these little air sacs. Measures that transiently increase the pressure to allow re-expansion, changing positions. Again, the dependent portions of the lung are the least well aerated. Air goes up, and it doesn't have as much stuff pushing down on it from the outside. So changing position from supine to upright. That's why, we all worry about skin, which is critically important, of course, but changing positions is critically important for the lungs as well. Early ambulation, incentive spirometry, acapella, all of those devices that respiratory uses, chest physiotherapy, problematic in patients with rib fractures. I went to see a patient today. She said she had no pain, and I pushed right where her fracture is. And she's like, I'm sorry, you said you weren't hurting. Tracheal suctioning, getting all that stuff up, helping patients cough when they're not intubated, positive pressure, and then prophylactically we use the incentive spirometry and so forth to help prevent atelectasis. Nebulized products, mucolytic agents like acetylcysteine, Mucomist, can be helpful if there's secretions in there that are kind of mucking the system up. And then for patients with cystic fibrosis who have significant secretions, very thick secretions, there's specific medications that can be used. So one of the things that we throw around a lot is atelectasis causing fever. And this is in every surgical book ever written, the 5 W's of postoperative fever. And they go, day 1, day 2, day 3, day 4, day 5. And atelectasis is always the first on the list. And we all go around saying, oh, they have a little bit of a low-grade fever, they must have some atelectasis. Get a chest x-ray, yep, they've got atelectasis. We've had patients who have had fever, and we do incentive spirometry with them, and the fever goes away. And we've all seen it on chest x-ray. It's a thing, right? It causes fever. And they even think that there's a mechanism with certain cytokines like interleukin-1 that potentially can incite the alveolar macrophages and have sort of endogenous pyrogenic qualities that make fever. However, of course, as with everything else in medicine, there's another side. And there have been several papers in the last probably 5 to 10 years that have questioned / kind of put this this long thought of thing to rest. So there have been no studies that have convincingly shown that there's a correlation between atelectasis seen on chest x-ray and a patient having fever. And there are also papers that show that people doing incentive spirometry doesn't stop fever from happening. So I leave it to you guys to decide. I think incentive spirometry is really important, so if you think that a patient has a fever and you want to give them incentive spirometry, go for it. I just am not sure that we have absolute proof that atelectasis does cause fever. It can, however, cause pleural effusions. So, and we'll talk a little bit about pleural effusions. That's fluid between the two layers of the visceral pleura, which is on the lung, and the parietal pleura, which lines the chest wall, the inside of the chest wall. So there's a space in there, and fluid can accumulate. We've all seen patients with pleural effusions. And a lot of the reason that pleural effusions don't happen all the time routinely is because there's contact between the visceral pleura and the parietal pleura. So that stops that contact, and atelectasis can mess that up, and it's the primary cause in patients with non-obstructive atelectasis. So that's atelectasis in a nutshell. Any questions, comments? The big thing we have to focus on is prevention. And the way we prevent it is with all the pulmonary things and all the physical therapy things. Hugely important. If you don't get rid of the atelectasis, then you move down the road to developing pneumonia. And that's why prevention of atelectasis and treatment as such is very important. Now, I've been doing this business for 28 years, and in 28 years, I have lost probably 100 hours of my life that I will never get back, at least 100 hours, figuring out what the definition of pneumonia is. It drives me insane. There's all kinds of definitions out there. Basically, the bottom line is a patient with fever, bad-looking secretions, white count, new infiltrate on chest x-ray, and needing oxygen. I mean, that's basically the clinical definition of it. There are ventilator-associated conditions. Then you get into ventilator-associated complications, and then you get into ventilator-associated pneumonia. It's just a mess. Basically, the bottom line is patients who are deteriorating from a pulmonary standpoint and have icky secretions and fever and white count, evidence of infection. So, fever, cough, particularly patients with purulent secretions, shortness of breath, needing oxygen, and all the other things, feeling lousy, not eating, all of those things. These are the symptoms. There's a lot of risk factors associated with this, and obviously trauma is one of them, in large part because trauma patients and hospitalized patients don't get up and move around, clear their secretions, keep their lungs clean, et cetera, et cetera. So that's why it's so important to do all that stuff. Pain, et cetera, all of those are risk factors. And basically what happens is those little air sacs, the alveoli, get filled with gunk, and with that gunk is white blood cells that cause kind of pus, and so the bacteria, they get obstructed, they don't get cleaned out, so the bacteria kind of can sit there and harbor and grow. It's kind of like a perfect culture medium. So how do we diagnose it? Well, we can't even figure out a definition, so it's hard to diagnose it if you can't figure it out, right? A lot of people, to complicate matters in terms of the definition, pneumonia has been deemed, in the hospital, pneumonia has been deemed a never event, which means that it should never happen. We all know that's crap. It happens because of all the reasons that we've been talking about, but nobody wants to own up to having a pneumonia, so that's why we try and call it something different, or we have this argument about what the definition is. Chest x-ray has only a 70% accuracy. So there's a lot of other reasons why chest x-rays can look abnormal, why you can have infiltrates, you have pulmonary contusions, you can have atelectasis, all kinds of other stuff that can look like a pneumonia on chest x-ray where the patient actually doesn't have pneumonia. And that's one of the reasons why the radiologist, there's no radiologist in the room, should never say that the patient has pneumonia. What they have on the chest x-ray is an infiltrate or a consolidation or something like that. But the pneumonia has to come with all the other stuff, right, that the radiologists have no idea about. On the other hand, you can have false negative where patient comes in with all the symptoms of pneumonia, fever, cough, secretions, but maybe they're so dehydrated that there's no fluid inside the lung because they're just so dehydrated. And then you give them a couple liters of fluid because they're dehydrated and they need it, and their infiltrate blossoms. So that's also possible. Because we have wanted to kind of define pneumonia a little bit better and because we want to not treat people with antibiotics that may have other things, we have come up with a bronchoscopic quantitative analysis. So in a lot of places, to define pneumonia, in the ICU, for example, we'll do a bronchoscopy, get in a very specific way, get a specimen from inside the lungs and send it to the lab, and the lab tells them how many, not only whether there's bacteria present, but how many colonies. And if you have over 10 to the 4th colony forming units, then you're considered to have pneumonia. And that has been shown to decrease the incidence of pneumonia, but more importantly, in my mind, decrease needing to give people antibiotics for treating it, which is always a good thing. You don't have to use antibiotics so that you don't get into all the other problems with antibiotics. So this is a pneumonia. You see that it looks not too dissimilar from the picture of atelectasis. So it's really hard to say. And this is on chest x-ray. The thing that is, and I probably should have put in here a picture of a pulmonary contusion because it looks exactly the same. The thing that you will notice about a pneumonia is that it follows the lobes of the lung. Right? So this straight line, nature is not into straight lines. So that straight line means that that's where the lobe ends, and that's where the pneumonia ends. It doesn't cross over into another lobe a little bit. A contusion or a bruise to the lung will just be wherever the lung is bruised. So that can cross lobar lines. So that's the big difference between pneumonia and pulmonary contusion on x-rays. Okay, so in addition to what the definition of pneumonia is, then we also get into where did the patient get it? And this is important because this will help us determine what bacteria we need to worry about. So patient comes into the emergency room with pneumonia, that's probably a community-acquired pneumonia. And that bacteriology is going to be different from the hospital-associated or acquired pneumonia, which may be different from a ventilator-associated pneumonia. And so these are the definitions of each of those kinds of pneumonias. And again, it's important because we want to, when we treat pneumonia, antibiotics obviously is the mainstay, and we need to tailor our antibiotics for what we think the patient is going to have. So in the outpatient setting, strep is probably the most common. Inpatient, we have to add things like the gram-negative bacteria, like H. flu. And then we also have to think about staph, like MRSA, and patients coming from nursing homes in the community are going to have a different bacteriology as ones coming from home, obviously, because they're exposed to more people who can be sicker and all that kind of stuff. So, treatment of pneumonia, antibiotics, go big or go home to begin with. So aim very broad spectrum, but then what we call de-escalate. So once the culture comes back and we see that it's not MRSA, we can take off the vancomycin because the patient doesn't need it. And the microbiology lab has more and more testing that they can do that gets us the answer a lot faster. So that's really been great to de-escalate. The reason we want to de-escalate or get rid of the antibiotics that we don't want is because we don't want the antibiotics to get resistant. So the narrower the drug, the less resistance is caused. Postural drainage. So any respiratory therapists here? No. So if you have a patient with pneumonia and we order chest physiotherapy, for example, we should tell the respiratory therapist which lung we're worried about, which part of the lung we're worried about. Because when they do postural drainage, we want gravity to help us. right? So if it's the lower lobes, for example, we want the patient's head down so that the secretions can come out when they're doing their postural, their percussions and all the stuff that they do. Antitussives, so cough medicine. It's not great to cough, and we like to suppress it to some extent, but remember, if there's stuff in there, if there's junk in there that needs to get out, cough suppressants can prevent that from happening. So it's kind of a double-edged sword. So use it, think about it with a little bit of trepidation. And then antipyretics. So everybody is always in the mood to get rid of fever. Well, God or whoever you believe created the universe created fever for a reason, right? To kill the bacteria. So while there are certain situations like brain injury, febrile seizures, that it's imperative to critically get rid of it ASAP. I know it doesn't make the patient feel great, but if the patient has a little bit of a low-grade fever, that's their body trying to help them get rid of the infection. So let's try not to jump on that so quickly all the time. I don't like patients not feeling great, but again, there's a reason for it being there. And it's kind of one of the reasons why, with our new multimodal pain management, all of our patients are on basically 4 grams of Tylenol a day. And Tylenol is one of the best antipyretic we have. So I kind of am stuck between this, if we really want to see if they're going to have an infection, but we're giving them Tylenol around the clock, how are we ever going to see it? So it's a conundrum. Any questions or comments about pneumonia? Yeah. We don't do it as often, and I am not sure why that is. But we, when we get called for a fever, we always get the chest X-ray, we always get the UA and the culture. Usually some blood cultures, which in the vast majority of cases are negative because they're not very useful. The best time to get a positive blood culture is right before the fever. So obviously we can't do that. So blood cultures are frequently negative. But we don't do the sputum culture as frequently as we should, and I'm not quite sure why that is. But we should probably do it more frequently. Yeah.
No, a lot of our patients that are under service that we have Tylenol, then you said ordered. Have you guys considered doing more opiates or something instead?
So the world, we are the big bad doctors that give too much opiates, and we've created this big crisis in the world. So we like to try and avoid the opiates, partially for that, but also, patients get constipated, they get more sedated. So there's problems with each of the drugs, right? The multimodal, I think, has really helped us avoid opiates as much as possible, although, we still use them quite a bit. But I think that, the whole Tylenol issue is a big one that we don't really take into account. And we probably need to think about that more often, especially the patients who have been here for a little while and who are more likely to be getting an infection and so forth. Any other questions or comments? Pleural effusion. So there's like I said before, a buildup of excess fluid between the pleura, the visceral and the parietal pleura. And the pleura basically acts to lubricate and make the lungs kind of go up and down easily. And normally there's a little bit of fluid in there, but pleural effusion is a significant amount of effusion, a significant amount of fluid. It can cause pain, dry cough, shortness of breath, and the inability for the patient to lay flat. There's basically 2 types of fluid effusions, transudative and exudative. Basically, exudative fluids are usually because of either infection or malignancy, and transudative fluids is just kind of fluid overload, very thin, from heart failure or something like that. exudative fluids tend to have like white blood cells or malignant cells or something like that. So here is a chest X-ray with an effusion, and you say, well, why is that not an infiltrate? That's a good question. But on this X-ray, you see the fluid kind of going up along the edge, so that's kind of more consistent with everybody see that? Up here. I'm short. So what do we do to get rid of effusions? Well, we can diurese the patient. Obviously, if the effusion is related to heart failure or fluid overload, then sometimes diuretics do work. Frequently, we have to get rid of the fluid by some sort of invasive way, either a thoracentesis, which is sticking a needle in and drawing the fluid off, or a chest tube. And then for recurrent effusions, particularly malignant effusions, that's not in the trauma world necessarily, but instilling what we call a sclerosing agent in can kind of make the pleura inflamed and then stick to one another, and then the effusion doesn't come back. And those are like things like bleomycin, tetracycline, talc. Talc is actually the best. And any of those agents are usually somewhere between 50 to 60, 70% effective. But again, most commonly used for malignant effusions. And this is a chest tube. That's where the chest tube lives, in the chest between the visceral and parietal pleura. And this is what happens when you put a chest tube in. Hopefully you get some of the fluid out, and then as the chest tube stays in, more of the fluid comes out. In terms of effusions and also hemothoraces, because we'll put that in there, surgery is frequently necessary. Sometimes we can do it videoscopically or video-assisted thoracoscopic surgery, or VATS, which is it's kind of the equivalent of laparoscopy but in the chest, and then or a thoracotomy, which is the open type of surgery. When we're dealing with hemothoraces, we're more likely to be able to do it thoracoscopically if we get it early in that liquid phase, rather than if it gets all sticky and clotty and everything stuck to everything. And then if it gets infected and there's what we call an empyema, that can be a mess. Any questions about pleural effusion? Comments? Then ARDS. So ARDS is another thing that is ARDS is a thing that is very well defined, because it carries with it a poor prognosis, and we like to, especially when we're doing studies, we want to do like compare apples to apples and not throw oranges and grapefruits in there. So basically, the term that used to be known, ARDS used to be known as, is non-cardiogenic pulmonary edema. So basically, diffuse pulmonary edema, multiple lobes, soon after a known risk factor, and the risk factors are almost everything. The trauma is definitely in the risk factors. And it is non-cardiogenic, meaning that the heart is working, it's not heart failure pulmonary edema, it's non-cardiogenic pulmonary edema. It's very usually is associated with refractory hypoxemia. So, like I said, lots of stuff can cause it, but these are the things that can cause it after trauma. And basically, even just the trauma itself can cause all of the cytokines and so forth to make the pulmonary capillaries leaky and cause pulmonary edema. This is what a chest X-ray looks like, just diffuse infiltrates. And then we have a chest CT. You can see again the lower lobe, the dependent portions are more affected than the non-dependent lungs. And I always like this. See where the arrow is, that black thing? That's a bronchus, and all the lung around it is just full of fluid, and that's air in that bronchus and bronchiole. So one of the things, so back in the day when I started this business, giving patients 20, 30, 40 liters of fluid, it would be not uncommon. How many of you have given more than like 5? Nowadays, you have? Are you old? Was it back in the day? Back in the day. Well, this article came out probably about 10, 15 years ago, and it started the question of, are we really doing the patient any good by giving them that much fluid? Comparing restrictive versus kind of at the day normal fluid management, and found that the restrictive fluid management caused less lung injury than the more fluid, the kind of conservative, if you will, what we did back then. And so this started the question of, we can't be doing this. We can't be giving 20 liters of fluid. We have to give them less fluid and maybe start pressors more frequently. I mean, we used to call leave-em-fed, leave-em-dead, because if you started the patient on those kind of medications, they died. They probably died of lung injury from all the fluid we were giving them, but we didn't realize that back then. There will be something 10 years from now that we're doing now that is really stupid, but we don't know it now. Anyway, this question has been asked in almost every significant group of patients, in sepsis, in trauma, in just any group of patients, and basically what the conclusion is that too much fluid is bad. We need to be very restrictive on our fluid management, and that decreases the incidence of acute lung injury, ARDS, and so forth. That's one thing. What else do we do? Proning is where we flip the patients, and it's very difficult in these complex, critically ill, hypoxemic patients, but it really helps. So if your lungs are all smushed down at the bottom, and that's where the blood is going, there's no air, there's blood, that's not a good combination. So we flip them, and the blood goes to where the area where the lung is not smushed, and there's less of a ventilation perfusion mismatch. Paralytics, sedatives and paralytics can help with patient ventilator dyssynchrony. So if the patient is bucking the ventilator at all, that's a major problem. It also decreases the oxygen consumption that the patient is using at a time when oxygen is at a premium. So that's good. And then lung protective strategies. Basically, we're using much lower tidal volumes and much lower pressures, and that has been very helpful. In fact, the only study that has shown to decrease mortality in ARDS is patients who have been using the ARSNet trial, which used low tidal volumes. So, in general, what do? Yay! If that's the only thing you got out of this lecture, very good. Early mobilization, incentive spirometry, get those lungs open, judicious fluids, we don't give as much as we used to, and that's still, even outside of the ICU, that's still probably true. But in the ICU, lung protective ventilator strategies, and then pain is a big factor in the road to developing pulmonary complications. So the multimodal pain management, whatever that looks like for your particular patient.
Dr. Shingo, who does early mobilization?
Everybody. If I'm on and you need me to come walk the patient, I will do it. You all know it. Any of you who know me know that I walk patients down the hallway. I'm happy to do it. This is one of the gajillion papers on the benefits of early mobilization. And even in the ICU, on the ventilator, bagging the patient. There's so many benefits from literally almost every organ system. Incentive spirometry has been looked at. Does it really work? It does when it's done properly. So this is a study that looks at specifically patient post-thoracic surgery, but there's been ones that have looked at abdominal surgery and so forth. So incentive spirometry really does work at getting the lungs open and decreasing pulmonary complications. The fluids, obviously we need to give some fluids, because if we don't give enough fluids, then there's organ hypoperfusion. The kidneys don't like that. The heart doesn't like that, etc. But if we give too much, then we run into a lot of these, pulmonary edema and increased pulmonary complications. So there's some happy medium in between, and sometimes that's hard to find. But that's why patients go to the ICU and have monitoring and so forth and so on. And then lung protective strategies, like I was talking about, the low tidal volume, low pressure ventilation strategies have been shown to be helpful, particularly in acute lung injury and ARDS. The multimodal pain management, we have, as I'm sure you're aware, we have a very elderly population. Did anyone notice that? You did, okay, good. Thought you would. So, again, from an opioid perspective, they are very much affected by it. So the muscle relaxants, I think, help a lot. The anti-inflammatory medications help a lot. Tylenol has actually been shown to be effective in pain control, other than just the anti-inflammatory process. But each one of these things has their own problem associated with it, right? But hopefully all together and each one used in moderation, you get all the pieces of the puzzle together. Questions? Yeah.
Your site protection, decreased tidal volume, decreased pressure. How does that help protect the lungs? Is it because they're more susceptible to pressure?
So yes, to some extent. So the pressure decreases barotrauma, so decreases trauma to the lung itself. The inside of the lung, the alveoli, are very, very fragile cells, and those are the cells that make surfactant, which keeps them open, keeps the alveoli open. So you don't want to damage those cells. And pressure and volume, overstretching with volume hurts those cells. We think that that's probably the mechanism by which it happens. Well, thanks for coming.